Good job.
Organization. All right, I'll go off camera until you all say we are ready.
Watching for a few more board members.
Oh yeah, we're 9 a.m. Just give it like 30 more seconds. How about? Do you still have me, Dave? Oh yeah, there we are. We're seeing, okay, there you go. Thank you for putting us in presentation mode. Dave, how many board members are we missing? Hi, Scott.
I think we're still looking for Tom McRobert and John Comerford.
Okay, we will give it just another few minutes.
Tom's joining right now.
Dave and Connie, I don't know if we need to be thinking about how we type in the closed caption directions for anybody that might. Wow.
Yeah, I'm thinking on this title slide, Sue, in the future that we'll have a little note at the bottom that lets people know how to turn on closed captioning in addition to the verbal remarks that you'll give at the beginning. You can add that to this opening slide.
Yep, perfect. Good morning, Elliot.
Morning.
Good to see you. Hi, Harry.
Yeah, good morning to you too. Thank you.
Do we have Leanne?
We should have everyone except for John, and Monica had let us know that she was very unlikely to be able to attend today's board meeting.
Okay, great.
We'll check on John as well. And it's
okay. I think yeah, I think we will go ahead and get started. So good morning. This is Director Birch, and I am calling this meeting to order. Today is July 14th. This is the Public Employee Board Benefits Board meeting. So welcome. I want to make a few general reminders, and then I will do board member introductions and the roll call. So thank you all for attending today and joining us. I do want to remind folks that due to COVID-19, the board has agreed to meet via Zoom only through the remainder of this board session. I want to also apologize. At our last meeting, we had some challenges, and I am glad to share since that meeting on June 30th, the closed captioning function is now accessible for these board members. An attendee must turn on the function on their Zoom meeting screen by going down to the bottom of the meeting window, and you'll see those choices down at the bottom there as you scroll your arrow down there. And you need to click on the CC, closed caption button, and select to enable those subtitles. I want to thank our attendees from the last meeting for bringing this to our attention. And I also want to thank Dave and the team for quickly working to address this important accessibility issue and to purchase the right licenses. We will, at the next meeting, have that on our introduction slide for people to read in case they are having trouble with that feature. Next, I'd like to have the board members identify themselves. So I'll do a quick roll call so that people can know who are with us today. So I'll begin with Elliot Weinstein.
Here.
Thank you. Tom McRobert.
Present.
Welcome, Tom. Harry Bossy.
Present.
Great. Leanne Kunze.
Present.
Thank you, Leanne. Scott Nicholson.
Present.
Awesome. John Comerford.
Present.
Thank you, John. And Monica Macklemore, I don't think Monica is able to join us, but she may be trying, but I believe she is overseas representing our country. Also, Michael Tunick from the Attorney General's office. Are you there, Michael? I think I saw you.
I'm present, Chair Birch. Thank you.
Fabulous. And I'm Sue Birch. I'm the chair. A few reminders, and we always do these, and I apologize for those of you that have heard this so many times, but for new people listening in, with both board members and presenters attending virtually, it's really helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are any questions. Board members, we will also watch in case you use your Zoom's raise your hand feature to indicate you have a question. And as I've said before, if you have to use your manual hand or your voice and we don't catch you, do jump in, but we've been successful thus far navigating all the input. For the public, you will have an opportunity to provide general comments at the end of the meeting during the public comment period. Now I'd like to ask Dave to go ahead and provide an overview of today's agenda. Dave?
Good morning, Chair Birch and members of the board. Dave Eisminger here. Today we'll start off with action on a resolution that Christine Davis brought to the board at the last board meeting on the 30th related to UMP accumulators. Just a reminder that for everyone in the public who may not have regularly attended board meetings, the chair does ask for public comment on resolutions before they are acted on as a separate public comment period, distinguished from the general public comment period at the end of the board meeting. So there'll be one resolution scheduled for action related to UMP benefit design. Then Tanya Dool from Finance will be here to present the non-Medicare risk pool rates. That's for our non-Medicare retirees as well as our active employees. And then we will have Ellen Wolfhagen join us with much of the presentation that had been originally scheduled for the 30th, but we moved to this meeting so that we could address public comment and hear from the public earlier at the last board meeting. So Ellen is here with a wealth of information and a preview of coming attractions. She will be a staple in board meetings for quite a long time. But this is just to kick off many of the questions and try to provide more information to the board and public about many questions that have been raised over the last month and a half. Then we will have a medical clinical insights presentation with our medical director, Emily Transu, Dr. Transu, and Luke Dearden from our pharmacy team. Again, a variety of questions. We just kind of segmented it to a clinical discussion and divided up the presentation that had originally been between Ellen and Luke, and decided Dr. Transu would be a good voice for that conversation as well. Then we will transition and have public comment and the meeting. The last thing I want to highlight is our lovely background today for Healthcare Authority members. Sue Birch, our chair, is highlighting it. It's the rhododendron, and she's coming to you visually from Point Defiance in Tacoma. We haven't had a Tacoma background yet, so just wanted to let people know what they are seeing from the backgrounds of the Healthcare Authority. And with that, I'll turn it back to you, Chair Birch.
Dave, thank you so much for that. I think we'll have a lot of good educational content and a little action, and it looks to be a great meeting. I neglected to share one very significant thing. Our very own leader, Dave Eisminger, has been selected for a very prestigious national fellowship on health policy. Now, don't panic. It does not mean he's leaving. It means that he will really be getting some very unique mentoring with a select group of folks. He is representing the state of Washington with the Milbank Fund, and equal numbers of legislative elected staff and then appointed or administrative staff form this group. And I have known about this for years. I actually met many of the Washington state legislators when I myself got this appointment years ago. Dave, you so earned this. And we are so proud. People don't realize that Dave brings things before the IRS. He gets Boeing and Microsoft and all the others moving forward. He's really cutting edge. And so it really is just a huge distinction, Dave, that you won this fellowship and that you'll be released offsite, 4 or 6 days a year. And so you make us proud. You keep doing this great pioneering work and keep challenging the medical complex. So Dave, thanks to you for all you do. And I know you're great team. I know you're going to say it's your great team around you, but you too are a wonderful emerging health policy leader. So I do ask the board and the public to have a bit of grace because Dave will have some key, I think there's only one on-site meeting, but that might mean we might have a few calendaring issues that we will cover for Dave or it's just really imperative that he do this work at the national level as well. Kudos to you, Dave. All right. With that said, let's move on to our first agenda item. This is the vote for the approval of the June 30, 2021 meeting minutes. And today we're going to vote on the June 30, 2021 meeting minutes. The minutes are behind tab 3. And I'd like to see if there are any comments from the board. No, you've all had time to look at those. Not hearing any comments. Do I have a motion to approve the minutes as written?
So move.
Second.
Thank you. I think that was Tom and Elliot for my second. All in favor, say aye.
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 Any opposed? All right, the June 30, 2021 minutes are approved as written. And that is our first item of business. Now we're going to move on to our next item. This is the follow-up from the June 30th, 2022 meeting. And Dave's going to provide some follow-up insights on a few of the questions from our June 30th meeting. So Dave, back to you.
Thank you, Chair Birch and members of the board. Again, I just had 2 pieces to follow up from. We obviously will, Ellen's presentations today, next week, and throughout the 2023 board season, will continue to address a variety of questions. But I did want to comment on 2 aspects of the last board meeting. The first is, as Chair Birch said, we do have the closed captioning feature that is now available. We've sorted out that functionality for board meetings, and I want to just say I do truly appreciate that this was brought to our attention at the last meeting, and it was something that immediately after the meeting I began consulting with our technology team to make sure we could address, and we were able to have that available, including to the sub-board meeting that was last Thursday. So we are up and running on the closed captioning function. Again, something very glad that was brought to our attention, and want to make sure that the board knows how serious I jumped on that personally to make sure that by the time we got to our next board meeting, even with the sub board last week, that we were able to have that functionality. And so glad that that accessibility is now here for the future for all of our board meetings. The last piece that I wanted to address was a specific question, was a parliamentary question that came up during the meeting at some point. There was a member of the public that asked or made an inquiry about the chair and the chair's voting privileges. I just wanted to highlight that in this instance, state law actually confers on this board who votes and who does not vote. And based on state law, the chair has full voting rights in this board. And so we know that Robert's Rules has information that kind of suggests both directions as to whether a chair should, can, when they will or won't vote. But in this instance, and in many instances for boards in our state, the legislature has spoken on the chair being a voting member and expressly indicates when the chair is not a voting member. So in this instance, because of state law, the chair has voting authority. I just wanted to address that specifically with a little bit of time to be able to research that and provide some instances. And for folks who want to see the board state law, it is RCW 41.05.055. Again, that was RCW 41.05.055. That's the last piece that I wanted to follow up with, and I turn it back to you, Chair Birch.
Thank you, Dave. Appreciate you and Michael running that down. And I remember asking that very question when I first began nearly 5 years ago. So appreciate that you found that exact citation. All right, let's move on to the next agenda item. This is the Uniform Medical Plan 2023 Benefit Resolution. Christine Davis, who is our UMP account manager, is back with the resolution for board action on UMP accumulators introduced at the June 30th meeting. And after Christine reviews the resolution, I'll read the resolution, And then I'll ask for a motion to adopt, and I'll get a second. And then I'll invite public comment on the resolution. I'll ask for discussion from the board until we are ready for a vote. And Christine's information is behind tab 4. Christine, I'm going to turn it over to you.
Thank you. Good morning, Chair Burge and members of the board. As said, I'm Christine Davis, and I will be presenting on the Uniform Medical Plan Resolution for benefit year 2023 for your action. Next slide, please. One recommendation for your action that we will be reviewing is Resolution 2022-14, also known as UMP accumulators. A similar resolution was presented to the SEB board, which is scheduled to be voted on next week, July 21st. Next slide, please. This slide was shared in the June 30th presentation. Just for reference, I wanted to represent it here. Currently, when a subscriber moves from one board to another, all of their accumulators start over, which means that they would start at 0 applied towards their deductible and out-of-pocket limit when they start with the new board. UMP is recommending that certain accumulators follow the subscriber when they switch boards mid-year due to a special open enrollment, as long as they remain within the UMP plan beginning January 1st, 2023. The board voted last year, PEB 2021-16, all accumulators currently follow the subscriber when they switch UMP plans within the same board mid-year due to a special open enrollment. So this change would result in a more equitable experience for UMP subscribers who leave the PEB board and join a UMP plan under the UMP plan under the SEB board. This resolution would result in accumulators for deductibles and out-of-pocket limits following the member, resulting in a lower cost share for the member. A similar resolution was presented to the SEB board, and this change would need to pass both boards to be implemented. Next slide. Bringing this resolution back to you, this language is unchanged from the presentation that took place on June 30th. Since this was presented to the board on June 30th, HA has received generally supportive responses from stakeholders. Board members will receive copies of the emails we received. Are there any comments or questions before we're back to Chair Bridge on this resolution?
Christine, I'm not seeing anything or hearing anything, so board member, okay, I think we're pretty clear. So board members, I will now call for a vote on the resolution PEB 2022-14 UMP accumulators. Resolved that beginning January 1, 2023, when a subscriber enrolled in a SEB program, Uniform Medical Plan, changes their enrollment to a PEB program, Uniform Medical Plan, during the plan year, excluding open enrollment, accumulated deductibles and out-of-pocket maximum expenses, both medical and pharmacy, will transfer. Is there a motion to adopt?
So moved.
Thank you, Tom, and I believe that second was Leanne. Are there?
Yes.
Thank you, Leanne. Are there any comments from the audience, from the public? If so, if you'll raise your hand or open your mics, we're watching. Are there any comments from the board? Okay, I'm not seeing any hand signals. So we're going to do a roll call vote. Elliot Weinstein.
Yes.
Thank you. Tom McRobert.
Yes.
Harry Bossy.
Yes.
Dan Kunze.
Yes.
Scott Nicholson.
Yes.
Monica McElmore has not joined us and is still absent from today. And I'm Sue Birch and I vote in the affirmative. So resolution PEB 2022-14 passes. Thank you, Christine. All right, we're going to move And there's Christine's contact information if anybody needs any further follow-up. We're going to move to our next agenda item. This is the 2023 PEB non-Medicare rates overview. Tanya Duell, who is our Herb Finance Manager, will introduce the non-Medicare rates for 2023 to prepare the board for action at our next meeting. And Tanya's materials are behind tab 5. And I remind again the public that we are discussing non-Medicare rates overview. Tanya, your materials behind tab 5, and I'm handing it off to you.
All right, thank you. So good morning, Chair Birch, members of the board. For the record, my name is Tanya Duell, and I am going to be walking through the employee and non-Medicare retiree premiums. As a reminder, the board did already take action on the 2023 Medicare premiums on June 30th. So next slide, actually one more, please. So we're going to start with employee premiums, and this is an annual great reminder that I bring back each year, and I think it's important just to go through this each year as a reminder of how we calculate the employer contribution for active employees. This methodology is established as part of the collective bargaining agreement and states that the state will contribute 85% of the weighted average projected healthcare costs. So I'm going to start at the top here, and we have 3 sample plan bid rates. The plan bid rates for Plan A is $550, Plan B is $500, and for Plan C is $450. So in this situation, we have 3 plans with 3 different bid rates. Then for Plan A, we have an assumption of 3 adult units that would be enrolled in Plan A, 1 adult unit enrolled in Plan B, and 6 enrolled in Plan C. So we take the cost of the plan bid rate multiplied by the adult unit to get the total monthly cost. So for Plan A, we would take that $550 times the assumed enrollment of 3 people, 3 adult units, and get a total monthly cost of $1,650. And we would do that for all the plans. We then add up the total monthly cost, so the $1,650, the $500, and the $2,700, and get a total monthly cost of $4,850. We then divide that total cost by 10 adult units. So the 3 adult units enrolled in Plan A, the 1 in B, and the 6 in C. We divide that by the total enrolled adult units to get a weighted average cost of $485. Then, per the collective bargaining agreement, we take that $485 total cost, multiply it by 85%, and we get the state's contribution, which is known as the state index rate, at $412. Now, keep in mind, this is just illustrative, and the state index rate is actually a bit higher than that this year. So we're going to move on to the next slide. We're going to take that same $412 state index rate, the employer contribution, and we're going to subtract that from each of the 3 plan bid rates. So we take the Plan A of $550, we subtract the $412, and we get an employee contribution for Plan A of $138. And we subtract that same $412 from all of the 3 plans. Now, if we move to the next slide, we then take that same $412, calculate the employee contributions, and then those employee contributions by plan are multiplied by the tiers. So we have a single subscriber tier, which is just that 1.0 tier. We have our subscriber and spouse or state registered domestic partner tier, which is ×2. We also have a $10 spouse charge that is added onto that. Our third tier is our subscriber and child or children. Regardless of how many children you have on your plan, it's ×1.75. And the final tier is the subscriber and spouse or state registered domestic partner and child or children. Again, as many children on your account, it's still ×2.75 and plus $10 for the spouse charge. Okay. So I'm going to move on now to the actual employee premiums proposed for calendar year 2023. But before we dive into these rates, I do want to add one quick note about the first fill benefit design change for Kaiser Washington. During the June 9th meeting, Beth walked through the proposed benefit design changes and verbally described the first fill change for Kaiser Washington. So I wanted to note that we have included the formal slide from that presentation as part of the appendix. And I wanted to note that because as part of the proposed benefit resolutions, the board actually adopts all benefit design changes for fully insured carriers by passing the premium resolutions. Okay, so back to the main event. We have the employee and employer premium contributions proposed for calendar year 23. On the far left, we have each of the plan names sorted by Kaiser Northwest, Kaiser Washington, and then Uniform Medical Plan. In that first column, we have the proposed 2023 single subscriber employee contribution. The middle column is the proposed 2023 employer contribution, known as the state index rate. And you'll note per my previous example that $665 stays the same regardless of plan choice. And on the far right, we have the proposed 2023 composite rates. So if you like to think of that example in kind of the opposite direction, if you take the far right column, which is the proposed composite rate, that's the bid rate in most cases, you subtract the state index rate, and then you get the employee premium for that single subscriber tier. On to the next slide. This slide shows the change in employee contributions as a result of our final round of rates. I'm going to walk through this table first. So again, on the left, you have each of the plan names sorted in the same order. The first two columns are the single subscriber tier for calendar year 22, so the current year's plan rates, as well as the proposed 2023 premiums. In the middle two columns, you have a change year over year from calendar year 22 to calendar year 23 in terms of percentage and dollars, as well as the PEB active enrollment subscriber count. So you'll notice on this slide, there are some plans that have increases as well as some that have decreases. To help explain this a bit further, I've actually included two new slides this year coming up that have a visual to try and help explain further the plan year 2023 proposed premiums. Next slide, please. So before we get into those two new slides, I just wanted to stop here and show the breakdown of each of the four tiers that I described so that math will follow those tier factors described on the previous slide. So we have the same plans on the left, the single subscriber tier, the subscriber and spouse or state registered domestic partner, the subscriber and child or children, and finally the subscriber and spouse or state registered domestic partner and child and children tier.
Tanya?
Yeah.
Can you, this is Director Birch, can you please clarify with UMP Classic why we aren't seeing kind of the same impact as we saw with our retirees? Why, for example, I guess my question is around, can you clarify about any other subsidies that we might receive as a state?
Yes. I actually have two slides coming up that talk about the differences between the two risk pools. So we can pause maybe and address that in a second.
Thank you.
Yeah, so there are distinct differences between the non-Medicare risk pool and the Medicare risk pool and the subsidies that are received in the Medicare risk pool, like you just mentioned. I will address a bit of that in a couple slides. As well as in the non-Medicare risk pool, while we experience similar trends, they are just structurally completely different, with the Medicare risk pool being a Medicare Coordination of Benefits program or plan, and the non-Medicare risk pool does not receive any subsidies, so or any secondary payments. So I'll get to that in just a minute, and then we can if you have any Director Birch, if you have any other questions, go ahead and ask me then.
Thank you.
Yep. Okay. So before we get into those, let's see. I have next slide, please. This is the first of the two new slides I wanted to walk through. And this first chart shows the total plan bid rates. So this is the combination of the employee and the employer contributions for Kaiser Northwest Classic, Kaiser Washington Classic, Kaiser Washington Value, UMP Classic, as well as the dotted line, which is the state index rate. So we chose these specific plans because they most closely align in terms of deductible and out-of-pocket maximums. So on the previous slide, we had employee premiums, which were showing some increases and some decreases. This slide is to show you the overall change in bid rate, which is increasing for all plans. So just a little note on the increasing bid rates. When we develop premiums and rates, we are developing them based on actual historic experience plus trend projections. We update those two components, base experience and trend, each year when we're setting rates. So as you can imagine, over the last couple of years, those two things have been actually quite hard to predict and somewhat volatile for the last couple of years. So for plan year 23, the current proposed rates, we're using actual 2021 experience as our base data, which is then trended forward to 23 using our best estimate trends. This is where we think actual cost and utilization will end up. So like I said, there's been really no roadmap for how to develop rates during a health pandemic. There's been a lot of uncertainty around 2021 and 2022 rate setting cycle, but I do want to let you know, we believe there's a little less uncertainty now that we have experience from a full calendar year during the pandemic of 2021. So like I said, things have been a little volatile and uncertain, but we believe they're a little less uncertain now. So I wanted to then kind of switch gears on this next slide. Since we just looked at bid rates, I want to describe a little bit and help illustrate why on certain plans, even though the bid rates are increasing, employee premiums can decrease. So next slide, please. So this slide is that second of the two new slides. So to orient you to this slide, you'll see 4 bars. I want to start by focusing on the left side of that darker gray bar. So the far 2 left bars. You'll see Kaiser Washington Classic calendar year 2022 compared to Kaiser Washington Classic 2023. If you look at the first far left bar, Kaiser Washington Classic 2022, you'll notice there's 2 sections of the bar. There's the state index rate at $604, and this is the employer's contribution, with an employee contribution of $204. That total bar equals $808. And that is the plan year 2022 total bid rate. When you look to the next bar, the Kaiser Washington 2023 bar, you'll see that the employer contribution increases from $604 to $665, but the employee premium decreases to $167, even though the total bar is increasing. And that is because the total bar for Kaiser Washington Classic 2023 is increasing at a rate less than the growth of the state index rate. So the employer's contribution is increasing 10%, while that total bar is only increasing 3%. So the state is actually picking up a greater share of that increase for Kaiser in 2023. Now, if we look at UMP, the far 2 right bars of that gray line, the opposite is actually happening. So we have a UMP Classic bid rate for 2022 of $714. And in 2023, we have a total bid rate of $801, which is actually a 12% increase. But like I mentioned in the example for Kaiser, the state index rate is increasing at 10%. So in this situation, the state's contribution increased at a lesser percentage than the bid rate. So the employee contribution is increasing. And I do want to pause here and see if there are any questions.
Tanya, this is Dave.
Yeah.
You had to explain this to me a couple of times, and I thought, I know the way that you said it that finally stuck with me, and I thought I would try to say it another way, because I know that I got lost in some of the questions myself. And so I think if we can go back to slide 9, the way that it really finally stuck stuck for me for folks is it's very subtle, but if you look at the slope of the lines from 2022 to 2023, they're all going up, but the blue line that's UMP is slightly steeper than the other lines. And so because UMP drives the average, the state index rate is an average, because it drives the average as it has the vast majority of enrollment, when the slope of the other carriers' lines is lower relative to UMP, you're going to end up in this phenomenon like we are this year, where UMP goes up from a dollar standpoint, while other carriers go down, because it's the relative increase to UMP, because UMP is driving the average. And so it's that very slight, subtle, steeper slope of the blue line compared to the other lines is not something you have seen historically, but that's why it's manifesting the way that it is in the premiums this year. But the overall trajectory of all of the plans has been generally the same. And so when you said it to that way, to me, that relative piece, because of the steepness of the blue line compared to the others, that's when it finally stuck to me, because it was counterintuitive. So hopefully that might have helped somebody else, because that definitely helped me. I see Elliot has a question. Elliot?
Yes, I'm just not clear as to why this is happening. Why is the curve steeper for UMP versus the other plans? Am I articulating this correctly?
Yeah, you are. Each of the plans are developed completely separately. Each of the plans takes their own base experience and their own trend assumptions and predicts what they are going to need for plan year 2023 to cover costs. The difference between the fully insured carriers and the uniform medical plan, they do have a structural difference on how they target how much revenue they need to cover the costs for the plan year. And Kaiser, Washington, and Northwest versus UMP, all three carriers do have different baseline assumptions within their plans, and they are somewhat different. There is different risk that is associated with each of the plans, so the revenue needed to cover the costs is different between each of the plans. Does that give you enough information? I can see your
I'll
head.
never totally get it, but I think that's about as good as it's going to get in my case.
Okay, yeah.
Anya, correct me if I'm wrong. This is Dave. It's all very subtle on slide 9, but year over year, there are some years where the slope, the blue line, is less steep relative to the others, and then this year it's higher. I think that was why you suggested this very slide, to show that overall, in an individual year, there's some steepness that is higher or lower relative to other plans, but overall, in the 5-year outlook, it's generally the same trajectory. Is that right?
Yep, that is correct. But there are some small nuances that each plan have within their underlying assumptions that do make them, maybe slightly higher in one year versus another plan, or slightly lower in another year versus another plan.
Dave, I would ask you and staff to think about how at our annual retreat we could continue to watch our historical trend. I feel like you've presented this to us in the past. I think there's a little distortion because the way the x-axis has for the visual in these graphs. I think we still, I think it would be wise that we compare to other states that have similar PEB arrangements and or to national trends. So if we could have that information at our annual board meeting again, I think that would be important for the full board. Tanya, I'm not seeing other questions. Do you want to proceed?
Yeah. So if we could skip forward to slide 12, please. One more. All right. So these are the non-Medicare rates. And I just want to clarify, non-Medicare means those retirees who are not yet eligible for Medicare and are not in the Medicare risk pool. So the non-Medicare retirees pay the total full bid rate plus an administrative charge and do not receive a direct subsidy from the state to lower the cost of their premiums. So again, on the left, we have the same plan names in order, sorted by Kaiser Northwest, Kaiser Washington, and UMP, comparing 2022 to the proposed 2023 premiums by the 4 tiers, as well as the change year over year in terms of percentage and dollars. Okay, next slide, please. So Chair Birch, these are the 2 new slides that are included because we did really want to touch on why there are differences between the non-Medicare risk pool and the Medicare risk pool. So briefly on this slide, I wanted to describe the 2 risk pools, which are set in statute. We have our non-Medicare risk pool, which is comprised of state employees and our early retirees. And that is different from the Medicare risk pool, which includes only Medicare retirees. So next slide, please. So again, this does tie back to questions we received in June by retirees as to why sometimes there are recommendations or resolutions that would only apply to Medicare retirees or the non-Medicare retirees. So firstly, state law does treat them differently from a rating perspective. Rates are completely independent from each other, and they are not in the same risk pool. So Medicare retirees are not included in the same risk pool or rates with the non-Medicare retirees or active employees. And secondly, I think this is the point you're trying to make. So we've talked through employee rates just now and how those are developed, including a state index rate. So an employer contribution, which is established by the collective bargaining agreement. We've also talked about how non-Medicare retirees pay the full bid rate. And then we've talked a lot this year about Medicare rates and how the Medicare rates include an explicit subsidy, which is a contribution from the states to lower their premium. And that is set at $183 or 50% of the premium, whichever is less. And for some of our Medicare plans, they also receive CMS subsidies to reduce premiums. So first, because of the statutory differences, as well as those really different financial distinctions between Medicare and non-Medicare, sometimes we will recommend proposals or resolutions that would only apply to one or the other risk pool. So sometimes we might have recommendations that would only apply to Medicare, or sometimes only the non-Medicare risk pool, which would include employees as well as non-Medicare retirees. So I want to pause there and see if that kind of answers those questions. Or Dave, is there anything else you want to add on this slide?
I see that Elliot has a question, so
Okay.
why don't we see Elliot's question, or hear Elliot's question?
Elliot, you're on mute.
You're on mute.
Yeah, I know. What happened was my, I had a technical problem and I fixed it myself. So I didn't know if the problem was at your end or my end. It was at my end.
Tanya and Dave, this is more kind of a commentary and just to see if you want to chime in, but we got a lot of subsidies going on writ large in the healthcare space to shore up a very expensive system. The exchange gets subsidies. I understand we have a 1332 waiver in motion. Is there any chance that we might see any federal movement for any more subsidization or change in these subsidizations of how writ large, no matter what type of insurance coverage you have, we subsidize this very expensive situation of healthcare offerings? Do you think anything's going to change? Do you think we'll see more or less of that? And do you think there'll be any sort of realignment as we keep going forward? What are your thoughts about that?
So I'll try to provide some insights. You know, a lot of a lot of that comes down to literally an act of Congress. We are putting together, because I'm anticipating that both stakeholders and legislators and everyone want to know this is exactly what federal law is it that would need to be amended. And so we have that together to be able to provide information about that. And we may even bring that at a future board meeting so that it's in a slide presentation as to when we say CMS subsidies can't come to this type of plan, where exactly is that in the United States Code? And that's where it gets back to, it's not discretion under CMS, it's actually the embodiment of federal statutes when it comes to CMS's ability to subsidize a plan like the Uniform Medical Plan and the Medicare risk pool. Acts of Congress on healthcare and grand bargains are, it seems historically, few and far between. And so, I think it is important for people to realize, though, that the federal subsidy aspect is in federal statute and would require congressional action on that point. When we think then about the state, the state has its own subsidy that is provided in the Medicare risk pool that's set biennially in the budget. And so then that is a funding question for our state as to what level that subsidy can, should, will be at any given point in the future. And so, I think the important theme of both of those insights is there is legislative action through budgets or statutory changes that really are at the heart of changing the structure that HCA works within today. That's kind of, I've heard people say, what are some of the challenges that HCA has in kind of managing the portfolio? And it's not that it's a challenge that's insurmountable, that is the structural world. Those federal statutes, federal rules, state statutes, state budget, those are kind of the fence posts and guardrails within which HCA works to bring rates. And so the changes to those require legislative action, regardless of which level that is, at the state or federal level. So
Thank you.
Those are the insights I have.
Dave, thank you for that. And I think as you do your national fellowship, I think the alignment too with Department of Labor and the ERISA regulations are going to be really important for us to stay abreast of. Just because this is an area that there's a lot of discussion going on of the unevenness of subsidies across the different markets, individual, ERISA, fully insured, just writ large, Medicare. There are lots of conversations going on. So thank you for that.
I think Harry has a question, and then Elliot.
Yeah, thank you, Dave. I'm thinking there's something known as an implied subsidy, and wondering if there's any value in mentioning that or discussing that.
Sure. I think Harry froze.
While it doesn't actually implicit quote benefit unquote for them. Is that correct?
Yeah, I'll go ahead and take that. Yeah, so in the non-Medicare risk pool, retirees who are not yet eligible for Medicare benefit from what's we call it an implicit subsidy, but it's not a direct subsidy. What it is non-Medicare retirees who are enrolled in the non-Medicare risk pool with active employees. It's a community rated premium that is primarily active employees. There's a small amount of early retirees in that risk pool. So those retirees benefit implicitly by getting lower premiums because they're community rated with a typically younger and healthier population. Does that answer your question, Harry?
Sure does. Thank you.
Yeah.
So again, Tanya, I think for our annual board meeting, it will be important too. The state employee demographics are changing and people are getting older. So I think that's going to be an important one to watch, especially in this new remote hybrid era. So again, I think that's a trend that I'm sure you all are on top of, but it'll be important to share with the board as we keep getting more insights into all of these changes. Great question, Harry. Other questions?
Elliot has another question.
Yes, I know that this is still up in the air, but I've been reading that in Congress, there is some talk about lowering the cost of drugs. And I'm sure Dave can be more specific on what's being proposed. If indeed something does happen, I request that it be discussed at our retreat and see if there are any implications from that legislation, because well, a lot is up in the air, but if it does get passed, I would like to learn more about it and see if it would help.
Elliot, so noted.
We will absolutely have something if there is federal legislation on that point. And the main feature that has been discussed in a variety of bills in Congress is about the direct negotiation of drug pricing on behalf of really everyone. And if something like that did pass at the federal level, it would have significant impact for everyone in our country, not just our state and not just in the Uniform Medical Plan. And that would be a seismic development that we will definitely discuss and would have very profound impacts. I think in many ways positive, but when there's any seismic change like that, it's not always positive for everyone, but there would be a significant impact on our plans as well as everyone's plans nationally. We will definitely bring something to the board if there is federal legislative action on a proposal like that.
I do want to call out, though, Elliot, and for other board members, I remind you that you all voted in a value-based formulary. Washington continues to be part of a very select elite group in drug utilization review and monitoring, and really Dave and team, the pharmacy team, especially and Dr. Transu, are really involved on this issue of pharmacy costs. And so we're already seen as at least positioned so much better than other states with our value-based formulary, but so much work to be done in pharmacy. And Dave's absolutely right. This is an area that none of us will be able to ignore. And we certainly will have a robust presentation and discussion, whichever way it goes. All right. Tanya, anything more?
Yeah, we have a few more slides to go. So next slide, we're going to start talking through the other benefits. So yes, thank you. Dental premiums. So as a reminder, dental premiums are 100% employer paid for our active employees, and retirees would pay these premiums. So effective 2023, the Delta Care rate shown on the screen comes with a 3-year rate guarantee, which would expire at the end of 2025. And then the Uniform Dental Plan, UDP, which is our self-insured product and administered by Delta Dental, has a 3-year rate guarantee also on the administrative portion of the rate. However, the small increase on the administrative fee with that rate guarantee was offset by dental claims experience. So we actually have a slight decrease on the Uniform Dental Plan. And then lastly, we have our Willamette Dental Group plan, which also has agreed, Willamette has agreed to continue their rate for another year, which would expire at the end of 2023. Next up, we have our life, AD&D, and long-term disability premiums. So for basic life and AD&D, and employer paid LTD, these are all employer funded, and there are no rate changes for 2023. For supplemental life and AD&D and employee paid LTD, these are employee funded, and there are no rate changes for 2023. However, to note, an employee might experience a rate change on a supplemental life or an employee paid LTD if they were to make either changes to their coverage for LTD or change within the age bands for life. Next up is the set of proposed resolutions. As a reminder, these are carrier specific, not plan specific. So by the board adopting the resolutions for the carrier, you're endorsing the employee premiums the non-Medicare rates, as well as any fully insured benefit design changes. So I'm not going to read each of them today, but for example, the first one, Kaiser Northwest, is on the screen. This is the proposed resolution PEB 2022-17 KP Northwest non-Medicare premium. The PEB board endorses the Kaiser Foundation Health Plan of the Northwest employee and non-Medicare retiree premiums. Next, we have this similar resolution for Kaiser Washington. And last, a similar resolution for the Uniform Medical Plan. So next steps, we will be back next week on July 20th to ask the board to take action on those 3 premium resolutions. And again, in the appendix is the detailed slide on the first fill program. And I will pause here for, yeah.
Tom has a question.
Yes, Tanya, I was wondering, when I look at those dental plans, does that mean we've dropped the idea of an incentive program?
No, so these are for plan year 2023. Any dental changes are going through a decision package process, which would be then considered in the governor's budget and would not be effective for plan year 23. Those would be in future rates. So anything that would impact the uniform dental plan would be in a future rate, not in these rates presented.
Okay, thank you.
You're welcome.
Thank you, Tanya. I think with no further questions, we're going to move on. Our next presenter and agenda item is.
Are you on mute?
I'm sorry, somebody unmuted. Our next presentation is about the Medicare portfolio comparisons. This is the agenda item from the last meeting that we postponed. Ellen Wolfgang has been waiting patiently. She's our senior account manager, and she's going to provide an overview of the Medicare benefit offerings in the PEB portfolio. And I, for one, am really excited for this presentation because it has a lot of really important information, and it puts in context kind of the challenges and the opportunities. So Ellen, I'm turning it over to you. Your materials are behind tab 6, I understand, and go ahead.
Thank you, Chair Birch. Good morning, Chair Birch and members of the board. For the record, my name is Ellen Wolfhagen, and I'm a senior account manager in the Employee and Retirees Benefits Division. Slide, please. First of all, I beg your indulgence because I have an allergy attack going on, so hopefully you can hear me. Today I'm going to talk generally about Medicare and the PEB portfolio. I'll also be comparing individual market plans from United Healthcare and group-sponsored plans from United Healthcare. We'll talk about prior authorization, claims, and appeals from both UMP and United Healthcare. Then we'll talk a little bit about provider networks. And then we're going to go into pretty specific detail on the PEB Medicare offering benefit design. And finally, we'll talk about retiree engagement. Next slide, please. So this is an overview of the different plans that are offered in the PEB Medicare portfolio. The first plan is the Uniform Medical Plan UMP Classic Medicare. This is a PPO, that's a preferred provider organization type of plan. This is self-insured and it coordinates benefits with Medicare. Original Medicare pays fee-for-service, that's FFS, on medical claims, and UMP pays secondary. This plan offers creditable drug coverage. I'll go into that in a minute. And the UMP plan pays primary on pharmacy claims. The next box is the Kaiser plans. These are HMO plans, health maintenance organizations. They tend to have a smaller network of providers, and they are regional plans. These plans also provide creditable drug coverage. The next box is the United Healthcare PEB Balance and PEB Complete plans. These are employer group waiver plans. They're Medicare Advantage plus prescription drug or Part D coverage. They're known as MAPD plans. These are PPO plans. They have a nationwide network, and there's no difference in cost share for the member between in-network and out-of-network care. These offer lower premiums and out-of-pocket costs, and there are no enrollment restrictions or additional costs for either pre-existing conditions or changing to a plan. Next box is the Premera Medicare Supplement plans, plans F and G. Plan F exists but is closed to new enrollment as of January 1, 2020. These plans are PPO plans, nationwide coverage. They are called Medigap plans because they were designed specifically to help enrollees fill in the gap that original Medicare does not cover. They cover medical services only. They do not include drug coverage. Next slide, please.
Real quick, Ellen, this is Dave. I just wanted to jump in and note one thing about the supplemental S plan. That was closed for enrollment because federal law required it nationwide to be closed for future enrollment. The plan was open to enrollment as long as it could be, but then at a point, federal law required Plan F to be closed. I also want to note that we've had a couple of retirees in correspondence and emails ask why we call them S and G. Why don't we have like a more a name that is more intuitive as to what it is? And you know, one of the challenges we have is the alphabet letters are used by CMS as a way to help try to standardize and give context to all the plans that exist out in the individual market that are available to retirees. It's sort of like on the health benefit exchange, people refer to bronze and silver and gold plans. Those are used as proxies to help people understand kind of upfront that all Fs have the same type of characteristics. All G plans have the same types of characteristics. And so we use those in our materials similarly to help convey at a kind of an instance that the type of plan that people are looking at. And yes, it is absolutely confusing to go, do I need an F and a D or a G and a D? I have A and B, what's the C? You can go through all the letters of the alphabet and it absolutely is confusing. The reason that that exists though is to help kind of convey standardization of certain benefit designs nationally. And before we go back to Ellen, we have several questions. We'll start with Elliot.
Thank you. I should probably know this, Ellen, but I don't. What's confusing for me when you talk about medical coverage only, now I'm assuming that doesn't mean chiro, that doesn't mean massage and naturopath. What I see as medical is not necessarily what the supplement plans see as medical. Is that true?
So that is true for the most part. The difference is there is some Medicare coverage for chiropractic. So it really depends. It's the Plan F and Plan G cover those services that Medicare covers under Part B coverage, B like boy. So if Part B generally covers a specific kind of chiropractic for spinal manipulation, then it would be covered. Generally speaking, though, when we talk about Medicare, medical, we're talking about primary care, specialists, and hospital care. And I'll go into that in just a second.
Next question was John and then Tom.
Yes, Dave. I just want to get clarification on Plan F. In the private sector, if you were eligible for Plan F on January 1st, 2020, you could still enroll in it. It was just not open to new Medicare participants after that date. Is that true also with the state?
Yes, that is true. So you had to have been enrolled already, or you were Medicare entitled prior to January 1, 2020, which in our case would have meant you had enrolled prior.
does that mean that, for instance, were I to be a state employee, a retiree rather, and was eligible for it on January 1st, 2020, but participated in another plan, that I could not, under the state rule, I'm not allowed to then enroll in Plan F?
So, John, it really depends on when you make your election with PEB. Remember that PEB has an annual open enrollment period.
Yep.
In
I'm talking about during
November.
open enrollment times. I just wanted to be clear because in the private sector, they do that all the time now.
John, I want to make sure we understand your question. I think you're saying in PEB during the annual open enrollment, can somebody who was eligible on January 1 of 2020 for Medicare still enroll in Plan F?
Absolutely, that's the question.
So again, it would depend on the PEB rules, because if you were eligible in January 1, 2020 and did not enroll in PEB until January 1, 2023, there would be a problem with meeting the PEB eligibility enrollment.
Okay, so there is a PEB rule that would,
yes.
I'm sorry?
We'll bring back more detail about Plan F enrollment because of your question, but there are limitations, yes.
Okay, the other thing I just wanted to bring out is the Kaiser plan and the United Healthcare plan get a subsidy for Part D or for the prescription drug program, but neither the UMP or the Primera receive that same kind of subsidy. So it's really, from a political standpoint, it's Medicare Advantage versus everything else. In terms of subsidies.
Going left to right on this chart, UMP does not receive the same substantial drug subsidies that either Kaiser or United receive. And then Primera supplemental Medigap plans don't have drug coverage, so that's not part of the equation for drug subsidies from CMS.
Yeah, I just want to be clear that when we talk about Medicare Advantage, we're talking about an entirely different animal that does receive that, and that's probably the law you're referring to in Congress that enacted that.
Yeah. Correct. Yes.
Okay.
We will bring back some more information about limitations on Plan F enrollment.
Thank you, David.
Good to flag that one. Tom.
Yes, Dave. Perhaps you can address this. I don't know if it's appropriate at this moment, but I've had people ask me, is the reason that they ended Plan F and replaced it with Plan G is not as a rich plan as Plan F was, and the federal government got rid of Plan F to save money. So I'm wondering if that's it. Let's just put it in the conspiracy theory portfolio and say that it's out there amongst people that that's why they did it. And I was wondering if you could address that.
So, Tom, the coverage is exactly the same in Plan G and Plan F. The difference is in Plan G, the member has to pay their Part B, like boy, deductible. So it used to be, you're absolutely correct, it used to be Plan F was a little bit richer because the plan paid the Part B deductible, and now the member has to pay that. But the coverage is exactly the same.
Thank you.
We can look into if there's any rationale explained in the federal decision-making process about why Plan F was closed, and try to bring that at the same time as we bring the insights for John's question.
Can I just follow up a little bit on that for 1 second?
Sure, John.
The insurance commissioner on the website puts out an excellent, and you can look at all the Medicare supplements and all of the various plans. And you can see the premium they charge for Plan G and Plan F. It makes no sense whatsoever. If you factor in the deductible for Part B, you would think it would be equal between Plan G and Plan F, and it's not. In some cases, it's less expensive to go with Plan G and pay the deductible yourself. In other cases, it's more expensive. if you go with the Plan F and don't pay the deductible. It doesn't make any sense. So I just want to make sure that people understand that this is not a sensible plan. It's a way that they manage healthcare in the country. So that's my 2 cents.
If we go back to Ellen, I would say there's a lot of counterintuitive things in healthcare, in the Medicare space, and the non-Medicare space, and that is where there's an important opportunity and challenge with providing comprehensive information for people to be able to make informed choices. And a hallmark of why Ellen is going to be a staple in our board meetings for the foreseeable future.
Dave and Ellen, this is Sue. I would ask you also to bring back a little bit more context and information about oversight. While the board has to have general oversight of all these things, there are particular rules that come along with Medicare, and John brought up OIC. So I think it's really important for the public to understand too, jurisdiction, rules, some of the authorizing environment where we have a little more latitude and where we don't. So that's just a future request, Ellen and Dave, to think about how we could suss that out.
Sounds like a great retreat topic.
Thank you. I'm just
Elliot?
packing that parking lot.
Yep. Elliot?
Sue just inspired me. I was having this thought while I was reviewing everything yesterday. For example, what I always wonder is, let's say there are appeals in any of the plans. Does the healthcare authority have any role in that? What can they do about it if the appeals are denied? Things like that, or other things once the plan gets going and they're being managed by any of these organizations. Can HCA come back next year and say, we're not going to agree to this contract if you stop holding up claims denials? What is the power of HCA in these environments? I, for one, maybe everyone else on PEB is totally knowledgeable, but I am ignorant of it, and I suspect there are members of the public who are too.
Definitely a topic for the retreat in January. Next slide, please. So this slide is how Original Medicare works with the PEB portfolio. And to Dave's point about the alphabet, we're going to do a little Sesame Street here, and I'm going to give you some alphabet. So under UMP, which coordinates with Medicare, medical claims are paid under Medicare Part A, which covers hospital, inpatient services, and Medicare Part B, which covers outpatient office visits, primary care physicians, and specialists. So those two are, Part A and Part B are known as Original Medicare. The health plan coordinates payment with Original Medicare. On medical claims, Medicare pays primary, UMP pays secondary. Again, on pharmacy, UMP is the only payer. On the Medicare Advantage, it covers Original Medicare, again, Parts A and B. The plans receive risk-adjusted federal dollars. It's a popular option for retirees seeking additional benefits, something called supplemental benefits, not covered by Original Medicare. These supplemental benefits are what Elliot was talking about earlier, such as chiropractic, acupuncture, massage therapy, or naturopathic services. These drugs offer creditable drug coverage, and again, I'm going to go into that in a minute, and HCA receives a retiree drug subsidy in part for those. The MAPD plans, the red column, covers Original Medicare, so Parts A and B, plus Medicare Part D. Some of you may recognize that Medicare Advantage plans are sometimes called Part C, which means they include Part A and B. So altogether, everybody, A plus B equals C plus Part D. That's what's covered under MAPD. Plans receive risk-adjusted revenue, and the Part D revenue is intended to cover approximately 75% of Part D drug costs. I want to note here again that our plans are employer group waiver plans, and they allow for customization of benefits and the formulary. The last column is the Medigap plans, supplement plans. You can be eligible either by age or disability. I'd like to note that PEB has a plan, and the OIC sells a different Plan G for state residents. It's also handled through Primera, but it's not part of PEB. These plans cover out-of-pocket costs for original Medicare, but they do not include any drug coverage. Next slide, please. So this is where I'm going to talk about creditable drug coverage. You'll see that the box for creditable drug coverage covers both UMP and the Kaisers. Creditable drug coverage has to be as good as Part D coverage. It may be better than Part D. It may offer lower costs. It may have higher costs for some drugs, and it may have a different formulary or specific drug. Part D coverage, which is under the MAPD plans, is regulated by CMS. Federal subsidies provide up to 75% of the cost, which reduces member costs. There is a standard formulary, but because PEB plans are subject to an employer group waiver, our formulary is negotiated. Next slide, please. Now I'm going to move into comparing individual market plans that are offered by United Healthcare and the MAPD group-sponsored plans that we have through United. Next slide, please. So the plan network design for the individual market, the commercial market, those are mostly AARP plans. They're mostly HMO, which means closed network. Our group-sponsored MAPD plans are PPO, any willing Medicare provider. Medicare, the maximum medical out-of-pocket, you will see on the AARP plans is very high. It can run from $5,000 to $6,500 in network and $10,000 out of network. The PEB Complete plan has a $500 maximum medical out-of-pocket limit. That's 1/10. PEB Balance plan, which balances a higher out-of-pocket with lower premium costs, has a $2,000 medical maximum out-of-pocket, which is still less than half of what's available on the individual market. In terms of copays, you'll see that there can be $0 in network on AARP and $25 for out of network. For PEB Complete, in network is $0, out of network is $0. Remember, the PEB plans were specifically negotiated to have no difference between in network and out of network. For PEB Balance, the copay is $15. Specialty copays run $35 to $45 in network, $65 out of network for individual plans. Under PEB Complete, specialty is $0 copay. Under PEB Balance, it's $30. For the pharmacy deductible, the tiers run $225 for the individual market. It's $100 under the PEB plans. I want to make a note. This says tiers 3 to 5, and as many of you are familiar with our plan design, you know we have only 4 tiers. And the reason is to accommodate some differences in how the plan tiers are set up. So they have been associated across a level playing field. And I also want to note that in the appendix, you will see detailed information that outline what's available for the individual market and what's available for us. The maximum out-of-pocket pharmacy, it is worth noting that there is no maximum limit for the individual market plans. For our plans, there's a $2,000 maximum out-of-pocket, and I'm going to talk a little bit more about that in just a second. The next line is the donut hole, and some people are familiar with this. CMS Part D has a point at which the member has to pay more for their drugs until they reach a catastrophic stage. That difference is called the donut hole. On the individual market, members have to pay more during that donut hole. On the PEB plans, these have been negotiated to prevent anybody from falling into the donut hole. So on the PEB plan, members pay just the applicable cost share or copay for the pharmacy tier all the way until they reach the $2,000 maximum out-of-pocket. If they reach that during the year, then they pay no more for their drugs until the end of the year.
Before we move on, Ellen, I just want to really try to drive home one point, that this slide is comparing United Healthcare underwritten PPO MAPD plans with AARP. I know I just used so many acronyms, but it's using United Healthcare underwritten AARP Medicare Advantage prescription drug plans that are PPO products with the United Healthcare underwritten and offered Medicare Advantage prescription drug PEB plans that are also PPO plans. So we're trying to show as close a comparison as possible, knowing that a lot of questions that have been asked and understandably are asked because most people are familiar with individual market plans. Employer-sponsored plans are something that a lot of people don't have access to and aren't familiar with because it's simply not as prevalent in the market as the individual market. But we wanted to try to show those direct comparisons from the United Healthcare underwritten products that people may be very familiar with on the private individual market compared to what was negotiated and is offered under the PEB program. And the appendix to Ella's presentation has a much more detailed comparison chart of all the United Healthcare plans under AARP, including their HMO plans. But this was designed as a snapshot to highlight at the high level some of those key benefits, coverage differences, and plan structure differences of as similar products as could be compared as possible.
I also want to note that in the appendix, the benefits shown are the 2022 benefits. We've made some plan changes for 2023 in the chiropractic and acupuncture visit limit and the drug tier copays. So if you see a difference, that's why there is that difference.
Before we move on, Elliot has a question.
Elliot?
Yes, thank you. I understand the purpose of this chart. Getting feedback from several RPEC members, they would like to see a chart that compared the commercial plans to the UMP plan with respect to drug coverage as well, just so that, because they wonder why nobody's talking about UMP. So that would be helpful for our membership.
Absolutely, Elliot. We will keep putting like I said, Ellen's going to be with us for many, many board meetings to come. And we do get a
Thank
question
God.
like this. Yeah, no, I'm glad that Ellen's going to be here too. There's a lot of information to share. This was designed, like I think you were alluding to, there were questions about United Healthcare plans, and so that's the answer to this question. We will certainly answer the additional question to the comparison with UMP. John, you have a question?
Yeah, Ellen, thank you so much. It's a great presentation. My question is having to do with premium for the individual. Are you going to show that in this slide, next slide?
No, unfortunately, John, I'm not doing the premiums today, but we can certainly bring that back next week.
I think it'd be worthwhile looking at the commercial premium versus the state subsidized PEB group premium.
John, I will highlight for everyone that in the appendix, slide 47, their premiums are noted as part of the more detailed table that's in the appendix.
Just for those.
Oh, great. I didn't see that. Thank you so much.
Just for the United AARP plans and the PEB Complete and Balanced United Healthcare plan. We can do the broader piece, but at least the parts that this slide 7 was on.
And that's,
there's
I'll
more
look at
detail on
that now. Thank you.
Thank you, John. Now, Tom has a
Page
question.
47.
Yes, 47. Tom?
Yeah, I know, Dave, you've addressed this not in a meeting, but in a conversation. There, on television, you often see in these commercial market plans, plans that have no monthly dues whatsoever. And I've had people ask, well, why haven't they considered one of those plans as being a market choice for PEB members? And I don't have an answer to that. Other than I think your comment was the devil is in the details, but perhaps it would be beneficial to put one of those plans up and compare those plans as well to, say, United Healthcare, Complete, or Balanced.
Yeah. I'll point you and everyone to slide 47 in the appendix. The first column there is an example of a $0 premium plan. And the way that many of those plans design, if there's no premium up front, then you have those higher out-of-pocket maximums, those higher copays. Those plans that have no premium typically have very high point of service costs. So there is a little bit of information that's in the appendix that can compare. And it has actually there are two examples of the zero premium plans within that chart as at least an initial sort of appetizer, if you will, to the answer to your question.
And if I may point out, so it's the first column in page 47 and the last column before the PEB Complete plans. Those are both zero premium plans, and one of them has a $6,500 out-of-pocket max. The other has a $5,500 in-network out-of-pocket max with a $10,000 out-of-pocket max. Comparing that to and these are medical maxes. You compare that to the second line on page 7, where our out-of-pocket maximum for medical for PEB Complete is $500 and $2,000 for PEB Balance. Okay, next slide, please. So one of the other key differences is with UHC, and I think this is something that Elliot was referring to as well. We have a dedicated a customer service team that's just for PEB retirees, so that when they call in, United can identify them right away as PEB retirees. We also have HCA staff like me available to help members navigate coverage issues. And that's a service for all the PEB retiree plans, not me personally, but all of the account managers are able to escalate issues and navigate coverage issues. Neither of these kinds of special care and feeding, if you will, are available to individuals enrolled in a private or commercial individual MA or MAPD plan. Next slide, please. HCA administers the eligibility and enrollment. I know we've gotten a lot of questions about people thinking that the carrier can just drop them after a year in the program. That's not how the PEB program is designed, and so our carriers cannot do that. A further difference is that as an entitlement in the PEB program, retirees can change their plans from any of the Medicare offerings to any other Medicare offering without restrictions that exist in the individual market. And again, that's during the annual open enrollment or meeting other enrollment restrictions.
Ellen, I just want to tie this together. I believe there was I remember this public comment from I think it was the end of the last board meeting, a gentleman from Spokane, his name may have been Matt or Mark, if I remember right. He and his wife were both speaking, and he brought up this exact point, asking, he said he struggled to find information about when you enroll in Medigap plans like Plan F for a year, then you're not able to enroll in other types of plans, and asking for that to be more prominent in PEB materials. And this is the answer to that question. That is a true statement for the individual market. It's not a restriction that exists within the PEB portfolio. You can be in Plan G for 4 years, longer, way longer than the year prohibition that exists in the individual market. And come annual open enrollment, you can switch to anything else. So just wanted to tie a bow on that, because that was a very, I knew you had this in your slides, and then that question came up. I was like, oh, we'll be able to say that next meeting.
And then finally, the HCA contract management team actively monitors and intervenes with all the carriers to ensure that they achieve contracted levels of customer service. And this, I would say, is a hallmark of our employer group waiver negotiated contracts. Now we're going to move into prior authorization claims and appeals. Next slide. So the UMP medical prior authorization process is an electronic prior authorization request. It's submitted through Availity Essentials. It can be submitted by fax if online is not available. Regents will make a decision within 15 calendar days unless it's supposed to be expedited, and then it's issued within 72 hours. Next slide, please. This slide is the Medicare-only 2021 UMP medical prior authorization. There were 1,858 requested. Of those, 1,667 were approved and 191 were denied. Slide, please. On appeals, UMP allows appeals to be received by phone, fax, email, or snail mail. There's a receipt acknowledgement within 72 hours, unless, of course, it's an expedited appeal because there's not time to do the receipt. MODA, which is the pharmacy, makes a decision within 30 days. MODA can extend that an additional 16 days if needed. Expedited appeals for both medical and pharmacy are decided within 72 hours. Slide, please. These are the MODA pharmacy appeals. Again, this is limited just to the Medicare population in UMP Classic. There were 2,323 prior authorizations denied. And then you can see the different levels of appeals. After a first level appeal, you can move to a second level appeal, which is also decided by Regents or MODA. And then there is an external agency that can handle appeals from the second level, and those are listed in the last row. Next slide, please. For UHC, the prior authorization request submitted. If there's not sufficient information, the authorization is denied, and that's because United has to abide by strict CMS timelines to protect patients. Prior requests under UHC are done before service is provided. With Medicare fee-for-service, the prioritization may be done after the service was already provided. Providers have to submit the prior authorization request, and again, any delays on their part may cause an initial denial on the part of United. Slide, please. These are the Medicare rules on how much time there is for making a decision. The overall rule is the decision must be decided as quickly as the member's health requires, no later than 72 hours for expedited requests, 30 days for standard requests, and payment-only requests, they have 60 days to make a decision. For Part D, which is the pharmacy, they have to make a decision within 24 hours for an expedited request, or 72 hours for a standard request. Next slide, please. These are numbers on the 2021 UHC medical appeals. You will see that these numbers are very low, but keep in mind there were only 3,191 total enrollees in UHC at the end of 2021.
Ellen, there's a question from Elliot.
Elliot?
Yes, on the previous slide with the authorization process, who enforces that? That's my concern. And I guess this will go to the retreat or something, but does Medicare do, like OSHA, which I used to work for, did inspections, unannounced inspections. Is there any way that Medicare is boots on the ground and what's the word? Enforces these rules? How are they enforced? And also I noticed on the other slide that you showed with medical appeals, I believe, those are pretty high rates, 86%. But I do understand, as you mentioned, these are low numbers, which may skew the results.
Yes, I'll just say, Elliot, I know that there will definitely, this is some of the information, and we know that there will be plenty more context and conversation and presentations and questions to answer around this process, and we can certainly talk about how CMS enforcement.
If I can clarify on this.
Go ahead, Ellen.
If I can clarify on this slide, Elliot. So, 2021 had a total of 22 appeals, which is out of the 3,000 enrollees is about 1% or less. And of those, the initial decision was overturned, and you're correct that there's a very high rate of that, but let me explain what most of that is. Most of that is because information came in after the deadline. So CMS enforces the deadline. United has to issue the initial decision within 72 hours if it's expedited, or the 30 days. If they don't have enough information to make the decision, they're going to deny it. As soon as more information comes in, then they can overturn that decision. The other thing is that a number of these are provider situations where the provider put in the wrong code or something like that, and these get settled out. Some of this is based on having a new plan, and there are some bugs that get worked out with providers interacting with United. Next slide, please. These are the 2021 UHC pharmacy prior authorizations. There were 192 that were denied. Again, the initial decision was overturned in a large number of these because of that influx of more information that came in after the initial deadline. Now we're going to look at provider networks. Slide, please. So one of the questions that often comes up is who determines the network? What role does HCA have in determining the network? And it's really important to note that HCA does not do direct provider contracting, even for UMP. So Regents and MODA for UMP, or Kaiser Washington or Kaiser Northwest, United, and in fact, Primera for Plan G, manage their own provider networks. Providers can join or leave a network as long as they're adequate notice. Our contracts usually require that they give at least 90 days notice and that they cover through the end of the current plan year. Neither HCA nor a carrier can require future participation in any plan, including UMP. Next slide, please. PEB retirees have expressed great concern about being able to see their current provider under the PEB plan. And the key question to ask is, does my provider accept the plan rather than is my provider in network? Because with UHC, it does not matter in terms of cost share whether the provider is in network or out of network. I do have good news. At least 97% of the providers in Regents network do accept United plans. So there is a great deal of overlap, and that should allay some fears in that regard. Regardless of network status, again, their member pays the same cost share, whether they're in network or out of network, which is an enhancement when compared to UMP. Next slide, please. There is a difference between contracted providers and non-contracted providers. Providers who are contracted have a network contract with UHC, and they appear in the UHC online provider directory. Non-contracted providers can accept the plan, and often do, and treat their patients and bill UHC even though they have not signed a contract. Again, only about 2% of the providers overall in the Regents network do not have contract or are not willing to bill United. Throughout the year, United reaches out to providers to educate them and encourage them to accept the plan. Often there are providers who didn't realize that they were billing United for the plan. Just as the members of the public have confusion between individual market plans and the PEB plans, providers can have that confusion as well. Next slide, please.
Real quick, Ellen, I do want to highlight, this question has definitely come up several times. The question is, can a non-contracted provider accept the plan and treat some patients, but not other patients? So let's say I'm the provider, can I accept, and Connie and Ellen are both PEB UHC complete members, can I accept the plan for Ellen, treat Ellen and bill United, but not do that for Connie? And the answer is no. The provider accepts it for all of their patients or none of their patients. There's not a distinguishing on a patient-by-patient basis. So did want to provide that, because that's definitely a question that's come up a few times.
Thank you, Dave. This is just to give folks a sense of where UMP retirees are. And you'll see King County has the overwhelming majority, Pierce County, Thurston County, Snohomish County. So generally the Puget Sound region is the basis. Those 4 counties account for almost half of all the UMP retirees. 89% of UMP Medicare retirees are within Washington County, which means 11% live outside. Dave, do you have some insights on that?
Yeah, this question comes up quite a bit too about what plans are available outside of Washington state, and that includes the other 49 states and U.S. territories, as well as international coverage. So, for context, that 11% of retirees who reside outside of Washington, that's also based on the address of record that they've provided us as their official residential location. So there is that one qualifier. If you're somebody who spends part of the year in one part of the country and part of the year in the other part of the country, our data is based on the address of record that you have in the system. So we have that 11% of the population has an address of record outside of Washington state. That's about 4,000 individuals. Just wanted to give a little bit of insight on where they are in the country. The most populous state for retirees outside of Washington is Arizona, then Oregon and Idaho, and then California. And all of those, Arizona, we have about 800 members, or subscribers. These are subscriber numbers. About 800 subscribers in Arizona, about 600 in each of Oregon and Idaho, about 375 in California, and from there we have several states that have between 1 and 200, and then we start to get into double digits. When it comes to international coverage, I will say we've had a lot of questions about international coverage, and that is a topic that we will be planning to bring in a future board presentation. There are a lot of details to work out to be able to describe the variety of questions that have come. But what I can say is we have such a small number of individuals who have given us an address of record that's international, that even telling you the number starts to verge on revealing protected health information. We generally do not share numbers that are below either, I'm rated 30 or 50. I think it's 30. So I'm saying we have less than 30 members who reside outside of the United States who are enrolled in Uniform Medical Plan Classic Medicare. So we will be answering those questions, but I will say we've had more questions about international coverage than members who live internationally. We are working on being able to provide an insight to both the board and the public, but I think that is important context. I think there's a belief that there are hundreds or thousands of individuals who live internationally, and our enrollment is very small for international enrollment in UMP Classic, Medicare. We will be coming back with more answers, but I wanted to provide that context at this point.
If I can just add color commentary to that, both UMP and the United Healthcare plans in PEB provide non-emergency coverage internationally, and under each of those plans, the member has to pay the full cost up front, and then the plan reimburses medical expenses at 100%. For both UMP and the United Healthcare MAPD plan. Slide, please. This is a map of sorts of Washington State and shows the plan availability. So the three plans are national plans. That's the Plan G, the UMP, and the MAPD plans. And then the Kaiser plans are regional, and the regional plans have some specific counties. So you will see that in the boxes that have 5 little squares in them, those are because those are covered by the Kaiser plans as well. Next slide, please. The most current information on which providers accept the plan should be answered by the plan directly, and here is contact information both by phone and website for each of the plans. Next slide, please. Now we're going to do a deep dive into the Medicare offerings in specific benefit design. Next slide, please. All of the plans are going to follow the same format. I have comparisons between UMP and each of the other plans. So reading from the top, we start with the medical deductible. Then we move into the maximum medical benefit out-of-pocket, inpatient services, then outpatient services. That would include outpatient surgery, outpatient mental health, primary care, specialty care, urgent care, and then an ER copay. You'll see a line that says supplemental benefits. Again, this is what Elliot was referring to earlier. These are not necessarily covered by original Medicare, but are provided under the other plans: chiropractic care, acupuncture, massage therapy. I want to make a note about routine vision exams and routine hearing exams and the hardware that goes with each of those. Medicare covers medically necessary vision exams and hearing exams, but not routine exams. So this is supplemental additional coverage that is provided. And then the last column is last row is gym membership. I also want to note that in the UMP column, you will note some percentages as well as dollar amounts. The percentages are co-insurance. Most of the other plans have co-pays, which is a strict dollar amount. Next slide, please. Again, I'm going to make some general statements here, but all of the plans follow the same comparison attributes. So here again, we have co-pays and co-insurance. I want to note that Tier 3 non-preferred brand name and specialty drugs, the last two rows under UMP, it says NA. It's not that these drugs are not covered, it's that the tier does not apply in UMP Classic. Different plans have different tier structures, which makes it difficult to compare because there's not a similarity. Under UMP, non-preferred brands and specialties are usually covered in Tier 1 or Tier 2. And Luke Dearden, one of our pharmacists, will shortly present more information on how some specific drugs are addressed under the various plans. Slide, please. This is KPWA, their Medicare Advantage plan. And again, the copay versus coinsurance applies. I do want to note that for 2023, they have a new change for vision hardware, which is reflected here. So for Kaiser Washington Medicare Advantage, the copay or the allowance for hardware is up to $300. Slide, please. Again, the specialty in Tier 3 for UMP is covered. It's just not covered under a tier structure like Kaiser's. Next slide, please. This is PEB complete. The only thing that I'm going to point out here is under the supplemental benefits, new for 2023. There's an increase in the number of visits for chiropractic care up to 24. Acupuncture is also up to 24. Massage has always been at 30. Slide, please. This is UHC's PEB balance. Again, the upper limits for chiropractic and acupuncture have been increased here as well and are shown in that column. Slide, please. On this slide, there are the new copays for 2023. United did have for 2022 a coinsurance, but has moved to a copay to make pricing more identifiable for members. I'd like to note that the up to pertains to every single plan that the member pays the lesser of the actual drug cost or the copay for that tier. So if, for example, I had a generic drug that cost $4.37, that would be my copay rather than the $5 under UHC plans, and that would also be true if that was the cost under UMP Classic.
Real quick, Ellen, we're definitely hearing over the last 45 days some questions and ideas about benefit design changes within the Uniform Medical Plan as ways to address the rising premium costs. And many of those are topics that have been reviewed in the past, and we'll re-engage on those. But this is actually a great example of one that has been, I've seen proposed a couple of times. Some members have said, what if you raise the generic cost in UMP from up to $10 to up to $15? Well, in the scenario that Ellen described, where her actual cost of that generic drug is $4.37, she's going to pay $4.37 regardless of whether the cap is $10 or $15. And there are certainly some drugs where individuals are paying what the cap is, but the vast majority of drugs that are being paid in that tier, you're paying the lesser amount under that cap. And so it might not be as intuitive as to the limited impact such a benefit design change would have. Now we'll provide data about those different pieces, but I just wanted to provide that as an illustrative example because that is one of the ideas that we've heard a couple of times. And just, as a perfect segue based on the example Ellen gave to just highlight that as something and some of the nuances with benefit design that have to be looked at. Ellen?
Thank you, Dan. Next slide, please. So you may notice that there's a difference on this slide in that there is no pharmacy information, and that's because Plan G does not include drug coverage. So this is simply the comparison between medical benefits for UMP and Premier Plan G. I do want to note that the plan deductible, Part B deductible, was $233 for plan year 2022. It has not yet been set by CMS for year 2023. So as soon as that becomes available, which is usually in the fall, we will make that known as well. Slide, please. We were asked to follow up how the different plans cover some of the different kinds of rehabilitation therapies, such as physical, occupational, and speech therapy. You will see that, again, UMP has a co-insurance structure. The other plans have a co-pay structure. There are some limitations on physical therapy, occupational therapy, and speech therapy imposed on the Medicare plans because Medicare requires a prior authorization. Slide, please. So this is a follow-up on chiropractic and acupuncture therapies. And this slide is the Medicare covered. So to Elliot's question earlier, some of this is covered by Medicare, but again, a lot of the Medicare Advantage plans cover what is not covered by Medicare. Slide, please. Massage therapy and naturopathic services are not covered by Medicare. Therefore, there would be no coverage at all under Premier Plan G. But it is covered by the Medicare Advantage plans, and it is covered by UMP Classic. Slide, please. Now we're going to move to retiree engagement. We have had lots of different questions come in, and I want you to know that we take all of this very seriously. We've made improvements to the retiree enrollment booklet last year, and we are going to continue to make improvements based on feedback. Engaging retirees means listening to their experiences and concerns with the plan, and also learning more about ideas for the Medicare portfolio, such as Dave just mentioned, ideas on changing the pharmacy deductibles. Okay, not deductibles, sorry. Next slide, please. These are some scheduled retiree engagements that we've either attended already or are on the schedule. And we are working very closely with WSSRA and WEA and RPEC, RPEC. And those are the retiree groups that represent lots of different retirees, but we are also engaging in specific conversations. Slide, please.
Real quick, I do just want to highlight, this slide says that we're meeting July 14th with an RPEC organized coalition to work on establishing in-person listening sessions. Yesterday, the coalition reached out. We've rescheduled that for next week. So I didn't want people to think that when we published the slides, we were intending to have a meeting this afternoon. Now it's next week. Just wanted to update that for the record. But we are very serious about our engagements. We're calling it kind of retiree engagements because there are a lot of organizations and stakeholders to involve. Some of that will be listening sessions in coordination with RPEC and other coalition leaders. Sometimes it'll be webinars. As this slide's highlighting, we're on a convention or leadership council road tour in the month of September. But there are a lot of different organizations that we'll be engaging with. So we're trying to, use the phrase retiree engagement as a larger, broader strategy to encompass listening sessions, webinars, conventions, benefits fairs, all the different ways that we'll be engaging with retirees. And there's a question from Elliot.
Yes, thank you. Dave, for the benefit of the listening public, could you explain why members of PEB are not part of these sessions? I think it would be helpful coming from you, because I'm getting questions.
I'm not sure I understand the question, Elliot, because for example, can you clarify your question?
Sure. On slide 40, for example, the idea is that as a PEB member, I'm basically primarily a PEB member. I am not an advocate. I'm not for RPEC or any other group. I represent this group, but first and foremost, I'm a neutral PEB member of the board.
Okay, I think I understand the question now. What the pieces that are described here, you're right, are leveraging, working with specific stakeholder organizations to help organize and have specific types of engagements. But HCA, we will host our own types of engagements directly with the population, with not necessarily leveraging and always working with a specific stakeholder group. So there will be opportunities to your point. I want to reassure people that if you aren't a member of RPEC or WISPR or WUAA, that doesn't mean we're not going to try to engage with you. This is just highlighting those specific opportunities that are kind of in the works for coordinating with some of the large stakeholder organizations, but it is not to the exclusion of a PEB member who is not a member of one of those organizations.
And I just want to clarify too that when Dave says we, members of the team include staff, include Dave, myself, my deputy, Lou, any member of our leadership team, because I do know this is a very robust outreach schedule. And I think, Dave, you are needing to be on the East Coast on one of the September 27th dates. So just a lot of grace. We will have different members of the team involved throughout all of these listening sessions and outreach opportunities. And we still welcome all sorts of emails and connections in other ways. Welcome phone calls and ongoing emails.
Next slide, please. So to follow up on what Director Birch just said, these are, the previous slide was the things that are already scheduled, but please feel free to put my email out there for people who want to get involved. I am available for any PEB member to contact me. I can tell you that there are lots of PEB members who have reached out to me when I make presentations. I always provide my email. I have hundreds of follow-up emails and luckily a very supportive staff in helping me address those. We are also reaching out to additional stakeholder groups. You know, stakeholder groups are simply an easier way for us to reach a lot of people at one time. And as Dave said, HCA will be hosting a variety of different engagements in different formats so that people can attend in a way that they are comfortable. At the end of 2023, certainly as part of the retreat in 2024, we will be talking about what we have heard, and I will be bringing that back to the board. Next slide, please. Again, the goal is to engage retirees so that they can share information that they have. We want to provide information about the funding and financial structure of how the PEB portfolio, Medicare portfolio works. And we want to describe how the PEB retiree plans are different from individual market plans. We want to use the insights that we receive to help us improve our future communications. We want to be able to share the challenges that Dave mentioned that are inherent based on the structure and the jurisdictional limitations of the retiree portfolio. And we want to rebuild and strengthen the relationship between HCA and PEB retirees. Slide, please. As well as involving members of HCA management and staff, we also invite board members to attend at least one retiree engagement, whether it's a group engagement or one of the HCA-hosted presentations. And I will be presenting initial insights from the 2022 engagement in January of 2023, as well as in January of 2024, coming back with all the things that we've heard through the year. And I will be providing periodic updates, as Dave said. You will see me often, and I will address concerns that are raised by the board or during these retiree engagements. And with that, I am open to questions.
Ellen, not a question so much as a comment. I really want to thank you and Dave. This is really robust, really thorough. I know it's really important that we continue down this path of trying to understand and listen and really get as much input as possible as we continue to try to influence both at the legislature and at the national level. So really, more than anything, it's just a huge appreciation for all the work. And, you know, I hope retirees and the nearly 100 folks that are listening in today really take to heart the work that staff are dedicating to this initiative. So thank you.
Thank you.
Dave, I am not seeing any other hands. I think with that, we will move on.
Birch, do you want to take just a few-minute break for people to stretch legs and use the bathroom?
I think that's great idea. We will hold off. Dr. Transu, give us 5 minutes just to do a stretch and bio break, and we will be back at 11:15-ish. Does that sound good?
Perfect.
All right. Everybody take a quick stretch break. Emily, you want to do a sound check?
Yes, thank you. Sorry, I just had a little audio glitch. Are you hearing me okay?
Yes, perfect. Thank you.
Wonderful, thanks. Sorry.
We're just waiting for the mothership to return. There they are. All right. I think we've got everybody coming back now. Dave. All right, we're going to go ahead and resume our activities. We're going to move into our next agenda item, medical clinical insights. Both Dr. Emily Transu and Luke Dearden. Dr. Transu is our medical director for our program, and Luke Dearden is our clinical pharmacist, and they're going to share their various clinical insights related to when retirees transition between plan offerings. Their presentations are behind tab 7. Emily, I'll turn it over to you.
Thanks so much, Chair Birch and board members. It's really always an honor and a pleasure to get to speak to all of you. As mentioned, I'm Emily Transu, I'm the medical director for the PEB and SEB programs, and Luke and I are here to give a little bit more of a clinical perspective on some of the topics that Ellen spoke to in her presentation. Specifically, I'm going to speak to some sort of high-level issues around continuity of care for people who are switching Medicare health plans, particularly switching into Kaiser or United. And then Luke will address pharmacy in quite a bit more detail. We can go to the next slide. So really speaking about continuity, there are kind of two main pieces of that to me. One is about keeping the same provider, and then about maintaining a care plan, whether that's about medications you might be taking, procedures that are planned, and so forth. And then we've also had some questions raised about the approach to experimental and investigational treatments in different plans, so we're going to touch on that as well. And we can go to the next slide. So in terms of keeping the same provider, that really comes down to two pieces. First, is the payer going to pay the provider, either by bringing them into the network or paying them a non-network payment? And then is the provider willing to accept that payment and to see the patient under that new arrangement? So moving on, we'll speak first to provider types that are covered by traditional Medicare. And as Ellen spoke about earlier, this is going to be kind of basically everybody except for some alternative and complementary medicine providers. On the KP side, on the whole, coverage is going to be limited to KP providers. Of course, there are exceptions for a specialized situation when there's no KP provider available. So if there's continuity across and there isn't a KP provider available, then that would be maintained. For United Healthcare's Medicare plan, and again, this is really just reiterating what Ellen already described in detail, United will work with any traditional Medicare provider, and that includes the vast majority of UMP's contracted providers. Those providers can choose to join the network or not, and there will be no difference in the cost to the member. So from UHC's perspective, it's really a very open process. Moving on the next slide to those provider types who are not covered under traditional Medicare. And again, as discussed a little bit earlier, that's going to include massage providers and naturopaths specifically. Acupuncture and chiropractic have very limited coverage in Medicare, so they're kind of a fusion group. Here with the non-traditional providers, you're going to see a stronger network element for all of the health plans. So for KP and for United both, these providers are covered, but they would need to be in contract, either in network or affiliated with the plan. So this is a place where we're going to see a little bit more limitation as people are switching networks with the question of whether a provider is contracted. And on the next slide, kind of switching around to the provider side. So first, there's really a question of whether the provider is willing to work with a carrier, whether they join the network or not. And we know, as Ellen described, that United will work with any willing provider, but is the reverse of that true as well? And we know that 97% or more of the providers that are in the UMP network too. But if there are issues with a small number of providers that are unwilling to work with United specifically, that's really something that we're going to be spending some more time understanding better in the coming months. As far as the question of whether a provider will see a patient if they take that insurance, this kind of boils down to, from a continuity perspective, if you're my existing patient and you're switching your insurance, is that going to turn you into kind of a new patient in terms of having to wait for a new patient appointment, which we know can be much longer than an appointment wait for an existing patient, or being turned away if the practice or the provider, if I'm close to new patients? So in general, this is not really an issue. The question of being new and getting into a practice is about the patient being new, not about the plan being new. So if you're established with me as your provider already, and I take your new insurance, then continuity shouldn't be an issue. So I might be close to somebody I've never seen before who's coming in with United or with whatever new plan. But if I've seen you already, if I do take that insurance at all, that shouldn't be an issue. Moving on to kind of the continuity of providers piece into the continuity of the care plan. So what if you're on a specific medication or you have a surgery planned and you're shifting from one plan to another? Luke is going to speak to the pharmacy piece of that in a lot more detail a little bit later. As far as procedures go, providers in general are pretty in tune to sending authorization requests to the new insurance if somebody is going through a change. So if I'm a provider and you have a gallbladder surgery planned or a knee replacement planned in January that need a prior auth, I'm going to be sending that authorization to the new plan and not to the old one. And that's something that as providers, we're pretty accustomed to. That's kind of standard operating procedure. If you're actually in the middle of an active plan of care, so say you're actually in the hospital on January 1st when your insurance changes, or cases like you're about to have, or you've recently had an organ transplant, or for certain cancer plans of care, in those situations of an active care plan, coverage would be extended with the existing care plan by the new coverage, by the new carrier, until things get to a stable point, at which point transitions could be considered. And then finally, I wanted to touch a little bit on experimental and investigational therapies, because that's a place where we've heard a number of questions expressed and concerns. So in general, for all of our health plans, and that includes UMP, as well as Kaiser and United, across the board, coverage of experimental and investigational therapies are not covered. They're an exclusion. That being said, there are certain exceptions that get made, situations where there really isn't another alternative available, or very rare treatment conditions where there might not be an established base of knowledge. So there are some exception processes, and the approach to those really can vary a little bit between plans. So just wanted to say we've heard those concerns, and that's going to be a topic for ongoing conversations, kind of understanding where there may be differences, even though the fundamental underlying principles are the same. Now I'm going to hand off to Luke to speak in a lot more detail about pharmacy.
Yeah, thanks, Dr. Transu, and good morning, Chair Birch and members of the board. My name is Luke, as previously mentioned, Luke Dearden, and I'm a clinical pharmacist on the team here at HCA. So we heard a lot of pharmacy-related questions over the last two board meetings in particular, and I wanted to provide some follow-up on those. And I also wanted to give an overview of UMP's most utilized drugs and how they are covered between the different Medicare options as of right now. Before we really get into that, though, I think it is important to talk about what a formulary is to provide appropriate context for this discussion. So a formulary, also sometimes called a preferred drug list, is a long list of drugs or products covered by a health plan, typically separated into several tiers with different cost shares. And formularies are really essential tools used by health plans to direct members to effective, safe, and high-value drugs. And as an example here, UMP Preferred Drug List has about 2,300 products listed on that list. Formularies, though, are living documents and do change from year to year, and often sometimes throughout the year, especially when new drugs are added to the market or removed from the market. Although formularies differ between health plans, Medicare plans are required to cover at least 2 drugs in each drug category. I have found, based on review, that usually they cover more than 2 drugs in each drug category, however. And next slide. I also wanted to follow up on how the UMP value formulary influenced UMP Medicare prescription drug costs. And as a side note, this is the first of 3 slides on this topic. But anyway, in 2020, UMP implemented a value formulary which directed members to the highest value prescription drugs without reducing quality of care. This effort primarily focused on non-specialty drug classes, and that's really because there is typically less opportunity to direct members to preferred alternatives if they are using a specialty drug. There's just not as many products available. So for UMP Medicare, we are seeing big year-over-year increases in specialty drug use and spend, which overshadowed the impact of the value formulary on trend growth. However, we were able to see that trend increased less than was originally expected. However, it's important to note, especially in the context of Medicare, is that no formulary management effort by itself will really be enough to overcome the structural disadvantage of the existing UMP Medicare plan, as we've discussed earlier today and in the previous 2 board meetings. Next slide. We wanted to dive into the value formulary a little bit more and mention why it's really not possible to determine an exact cost impact of the value formulary, especially as an isolated benefit change. Some of the factors involved that change year to year, for example, is a rapid increase in specialty drug cost. And I want to remind everybody that while specialty drugs account for about 1.4% of the total prescription drug utilization, they account for about 58% of the total plan spend. Also, expansion of the protected drug classes when the value formulary was implemented is a factor. So originally, there were 6 refill protected classes proposed, meaning members were able to continue their existing medication in these classes without having to switch to something else. That turned into 20 refill protected classes by final approval, which will lower the savings potential. There are changes in drug costs and rebate offerings year over year, changes to the preferred drug list, new drugs coming to the market, some drugs being removed, new generics coming into the market. Evolving disease state guidelines, which really influences prescribing patterns, shifts in plan membership, and then of course, COVID hit in 2020 when this value formulary was implemented. I do want to take a second to note, though, that even though we're unable to attribute a specific cost saving to the value formulary by itself, as I mentioned, we have seen that the pharmacy trend has increased less than what was originally estimated in 2019. The The value formulary may not be able to take all of the credit for that, but it was certainly a contributing factor in addition to our ongoing prescription drug management. Next slide. It's really important here to call out in this presentation some of the benefits we did see from the value formulary. First, you may remember that it resolved a member equity issue. So prior to implementation, members who used medications covered at the Tier 3 cost share had the ability to get an exception. And if that exception was approved, that member would pay a Tier 2 or a lower cost share. Not all members knew about this exception opportunity, and therefore there were members on the same drug that were paying different cost shares. So this was a critical benefit of implementing the value formulary. Second, it provided savings directly to members out of pocket. Before implementation, many members were paying a 50% coinsurance for those Tier 3 non-preferred drugs, and members now pay a 30% up to a maximum of $75 per 30 day for the same or similar drug. So when you're talking about a non-preferred drug that is $800, members could pay up to $400 per month for that drug. Now they're paying a maximum of $75 for that drug or a similar drug. And then, as I mentioned earlier, the value formulary certainly contributed in addition to ongoing management of the prescription drug benefit to reduce the pace of pharmacy trend growth compared to what we had anticipated back in 2019. I want to pause here and just ask if there's any questions related to the value formulary before I move on. All right, we can head to the next slide. Another concern that was brought up at the last couple of board meetings was whether members would be able to continue their existing medications without having to step through other medications if they decided to switch to another plan. So, and this slide is specific to going from UMP to United Healthcare. So Part D sponsored plan formularies in general do require coverage of basically all drugs in the following classes. So immunosuppressants, usually used in the setting of transplant, antidepressants, antipsychotics, anticonvulsants used for seizure disorders or even as mood stabilizers, antiretrovirals for HIV, and then anti-neoplastics for cancer. You may recognize these classes as some of the same refill protected classes outlined in the value formulary implementation, meaning members were able to continue their existing medication in these classes without having to switch to something else. So we would expect the same here if a member were to switch from UMP to United Health, where if someone has already gone through step therapy on any of the above drug classes while on UMP, they should not need to satisfy that step therapy again for these classes. Next slide, please. Next slide.
Some people in the public might be wondering, why we're still focused on describing things related to the United Healthcare plan from a UMP switch. We're trying to answer as many of the questions. There's a couple of reasons. We're trying to answer as many of the questions that came up over the last 45 days. And we've described that one of the things that we want to do is provide information that might not be well understood or that we haven't been able to get before members for full appreciation of some of the differences between the plan portfolio. So we're really focused on trying to answer those types of questions. I just realized as a figure, the context in which the presentation was originally created on the 30th is not the same context we're in today, because there is no proposal under consideration related to UMP Classic Medicare, but wanted to kind of give that context as to why there's still so much focus on UMP and UHC comparisons. The second piece is on this last bullet on slide 12. There's a question that I anticipate might be asked that goes something like this. What if the step therapy in UMP during the value formulary involved drugs A and B, but the step therapy that's at United involves step drugs C and D? Because C and D aren't the same as A and B, you got to go through step therapy again? And the conversation with United was no. So just wanted to provide that additional context, because I think that's a natural question that I had, and something that it would be very, I would anticipate would come up, and wanted to share that as well. So back to you, Luke.
Yeah, thanks, Dave. Yeah, that's true, especially for those 6 drug classes where, it would be perhaps devastating if you required somebody to switch a drug in one of those classes, especially for like a transplant situation. Anyway, slide 13, the drug classes listed on the left side of this slide in the table are additional refill protected classes that were also part of the value formulary discussion and implementation. For drug classes in the top row, again, per discussions with United Healthcare, if step therapy or a prior authorization is required for drugs in these classes, they would work with UMP to automatically transfer active approvals, really allowing for uninterrupted coverage as well for those drug classes. And then the same is true for the drug classes in the bottom row, except there are currently, and it could change year to year, 10 drugs within those classes where a member may need to switch to an alternative. I want to point out that the 10 medications listed on this slide are relatively rare. Several of them, in fact, have no utilization in the UMP Medicare population, at least within the last quarter. And all of these medications combined, except for Pradaxa, are used by less than 50 members combined. I was going to call out Pradaxa specifically, which is an anticoagulation medication, and it's currently used by about 280 Medicare members. However, I was pleased to see that a generic for Pradaxa very recently entered the market. So moving forward, especially in 2023 or 2024, I'd anticipate a more streamlined transition for a member who may be taking the generic version of Pradaxa if they were to switch from UMP to UHC. Next slide. Yeah, so just calling out that new prescriptions for the 20 drug classes on the prior slides may require either step therapy or prior authorization in a United Health or any other Medicare plan. Just like UMP, it's the same for UMP, calling out that new prescriptions are handled differently than if you are already on a medication and you wish to continue it. And then, as I mentioned in the previous slides, the 20 drug classes that were listed were those drug classes handled with extra protections when implementing the UMP value formulary in 2020. Yeah, and a question from Elliot, it looks like.
Yes, I'm not familiar with what step therapy is. Perhaps everyone else knows, but I don't.
Yeah, that's a great question. So step therapy is when a health plan requires a member to try a certain drug before they are approved for the drug they're requesting.
Thank you.
And
So the
oftentimes,
typical,
oh, go ahead.
the typical scenario on that is that there might be several, a number of medications that are therapeutically very similar in terms of how well they work for people, some of which are going to be a lot less expensive than others. And so the step therapy process basically says, if you're coming into this, you haven't tried any before, what you're going to start with are the ones that are going to be most cost effective. And then if those don't work for you, then you would move on to another.
Yeah, exactly.
Sorry, go ahead, Luke.
All right. Is there another, looks like another question from Scott?
Yeah, question of who determines the timing for the effectiveness? Is that a determination made by the medical provider? Is that an insurance determination? In terms of how long do they have to wait at a certain step before they get, and does that vary by drug? And what's the decision criteria to allow a member to say, okay, this isn't working for me. How do I move on from this step to the next one?
Yeah, that's a great question. So it does vary by individual drug. And oftentimes, I'll use an example of antidepressants. We know from reviewing a lot of literature that antidepressants can take, sometimes about 6 to 8 weeks to become fully effective. So if there is a large body of evidence saying, okay, this is how long a certain drug takes to become fully effective, that's probably what the requirement will be. Other times when there's less evidence out there, it is typically defined more in generalities, usually anywhere between, I would say, 2 months and 3 months. But typically when you're looking at a drug, there is clinical studies on that drug that it used to gain approval by the FDA. And that will give you an idea of how long it takes for, to be fully effective.
Yeah, I think about it in the context of, sorry, go ahead. Go ahead, Emily, sorry.
I was just going to say that would differ also if it was a question of effectiveness versus the question of an adverse reaction. Obviously, if you develop a rash, you're not going to say wait a couple months. So it's sort of a question of whether it's effectiveness or whether it's reaction. Sorry to interrupt. Go ahead.
Oh no, that's a great point. So yeah, exactly. If sometimes a step drug is not appropriate, there's some kind of medical reason why the member couldn't take that, then that would also be a reason why they'd move directly to the drug they're requesting. And that's usually information that the provider and the member has, or the provider has documented.
Thanks. Is there, and this is my last question on this, is that some of the illnesses in your examples can have pretty severe consequences if left untreated. Range all the way up to suicide and the idea of depressants. So, is there a mechanism by which your provider can move ahead with something, and how much does that vary by plan?
Yeah, so that's a good question. And so I think, like with the antidepressant example, it would certainly be handled differently if they started somebody on that, medication, and then that person started actually getting worse.
Yeah.
At that time, you could treat it as more of like an adverse reaction situation where it's like, okay, yeah, we need to move to the next step here. But if you can see that they're not getting better, there are other options. Very commonly in depression, providers will add a second drug, which could help as well. And does that answer your question? But
yeah, just as long as I'm just trying to get to understanding if there are mechanisms to get outside of a formulaic I know that's probably a loaded term to use, a formula process, but like a step-driven process of you do this, you do this, you do this, based upon the circumstances, that is not necessarily dictated by the insurance plan, but is more about the conversation with the provider and what they're seeing with the patient.
Definitely there is a process for that, and there's exceptions to all of these formulary management tools that the provider or member could initiate. There's peer-to-peers where a pharmacist who's reviewing the request can talk directly to the provider to get more perspective. So there's definitely processes for that with UMP, and then with any other health plan as well.
Thank you.
I also want to just jump in. I think there can be a little bit of a misconception around step therapy, that it's sort of like you start with the weaker ones, and then if those don't work, you can get on to the better ones. Whereas in general, there's pretty much therapeutic equivalence. Of course, of any 100 people, you're going to have some who respond differently to one or another, but this isn't a like start with the thing that's not really likely to work and then do your time with that and then go on to the one that will. It's really there's a bunch of things in each class that tend to be very much the same. Start with the ones that are going to also cost less, and then move on for that small percentage of people who need it. I'm not saying that was your question specifically, but I feel as though that current sometimes runs under this conversation, and I just wanted to call it out.
I appreciate that. What I heard from our members from our last vote our resolution discussion last week or last board meeting was a concern that brought up related to the steps process, and really feeling that UMP provided an offering that other plans did not in that area and that maybe it was an easier process for them, and they were concerned about losing that. So obviously I wanted to know about how other plans do treat that for our retirees, as well as recognize that while people are going through medical conditions, they may think that something that's been around for 15 years may be less than the greatest or newest thing that they just saw on TV or whatever, but that there is a process for that decision to be made between the medical provider, the one providing the services, rather than just a cost saving measure. Thanks.
Dr. Transu and Luke, isn't it fair to suggest that kind of these outliers are handled in a kind of care management, providers and pharmacy, environment where you guys are really working together to try to figure a path forward? It feels to me as a nurse that these get a lot of attention as they go through the process. Is that true?
I would say that
it depends on, yeah. And I would say it also depends to some extent on the clinical circumstances. If I have mild hypertension, it's going to take a long time for that to cause any medical consequences for me. And so having a little bit more of a gradual process of try something else, that can be a little bit less kind of handheld versus when the circumstances are something that's got a little bit more acuity to it. And those are the ones that I think do get a lot of handholding.
Yeah, I guess I just want to dispel the thought, though, that this is just, some algorithmic step thing, because I know between Luke and Donna, the pharmacy team, I just have heard and feel like there's a fair amount of time and energy put into this process.
Yeah, absolutely. Our goal is to get members who need care help that they really need. So there is a lot of time put into cases like this, and they are handled on a case-by-case basis in a lot of situations.
And as you consider plan changes or making decisions in the future, this is something we heard in public comment last board meeting, and will need to be addressed either through a communication mechanism of how this aspect, depending on where UMP goes, is handled differently or will be handled just the same in these other plans. Because it also rang true as well in the documentation that was provided by members and their concerns. So just food for thought.
Thanks, Scott. Other questions from board members? All right, I am not seeing any. Do you guys have any further slides? Oh, Tom's hand just shot up. Go ahead, Tom.
There are.
I'll save my questions until the end of the presentation.
Okay, go ahead and proceed, Luke.
All right, great. So transitioning to more of a review of the formulary and also utilization. There are about 53,500 total UMP Medicare members. 97% of them have used the prescription drug benefit at least once in 2022. 95% have used at least one generic product. 38% have used at least one non-specialty brand product, and then 3.4% have used at least one specialty product. And I think this breakdown is helpful context when we start to review the cost shares of the different drug types. Next slide.
Real quick, Luke, I just want to share with the board that this part of the presentation that was created for June 30th was designed in response to the question on June 9th, where HCA was asked to produce a formulary comparison of every drug between UMP and UHC. And so as Luke highlighted, there are thousands of drugs in the formulary, but I did want to give the context as to where this part of the presentation came from, was to give some insight on that question that was asked on June 9th. Wanted to say that, meant to say that as you opened up. Back to you, Luke, sorry.
No problem, thanks. This is just a different way of looking at utilization. So instead of utilization by number of members, this is UMP utilization by number of prescriptions filled. So 88.4% of prescription drugs dispensed from pharmacies have been generic in 2022, 10.2% brand, and then 1.4% have been those specialty. Just calling out again that 1.4% of specialty is responsible for about 58% of plan spend, however, prescription drug plan spend. Next slide. So with all of this context, we compiled UMP's top 10 utilized drug for each drug type, so generic, brand, and specialty, and compared UMP's coverage to coverage provided by United Healthcare, Kaiser Washington, and Kaiser Northwest. And just calling out that this comparison could change year to year, as formularies often do change. For orientation, the percentage in the left-hand column next to the drug name represents the percentage of UMP Medicare members who are using each medication. So for example, atorvastatin which is a very common medication for high cholesterol, is used by about 28% of UMP Medicare members. Atorvastatin, along with other statin medications listed near the bottom of this slide, simvastatin and rosuvastatin, are covered with a $0 copay for UMP. And also at least one of the other plans covers them without copay as well. Levothyroxine, the second most used drug, is a drug used for low thyroid levels. It's covered at UMP's standard generic cost share, which is 10% up to a maximum of $25. And then covered with a copay of up to $5 for United, up to $20 for Kaiser Washington, and up to $15 for Kaiser Northwest. I do want to note, just reiterate something that Ellen said earlier in her presentation, is that for United and the Kaiser plan, if the drug cost is less than the copay amount, the member will pay the cost of the drug, as is likely the case for a drug like levothyroxine and probably most of these 10 drugs listed on this slide. Lisinopril, amlodipine, losartan, metoprolol, and then on the last row here, hydrochlorothiazide, are all pretty common blood pressure medications. All are on the UMP's value tier, which has a 5% up to $10 per 30-day maximum. And then finally, gabapentin, most commonly it's used for nerve-related pain, is also on the generic tier, which is 10% up to a maximum of $25. For context, 5 to 10% cost share for these medications through UMP is going to be pretty low. It's going to be about 50 cents to $1 per 30-day supply. And then some also might be surprised that there are no generic medications for diabetes listed here. I just wanted to call that out. Metformin is the most commonly used diabetes medication, and it's just barely off this list, coming in at the 14th most utilized drug. So also very commonly used, just not quite as common as these blood pressure and cholesterol and thyroid medications. Next slide.
Do you have a 10?
Moving to brand name, non-specialty drugs. Eliquis, which is an anticoagulant, is by far the most used at 9% of the population. Eliquis and a similar medication that's further down this list, Xarelto, are covered at UMP's standard preferred brand tier, which is 30% up to a maximum of $75 per month. You'll notice that the cost share is $30 less per month for United Health and $35 less per month for Kaiser Northwest, for example. I also wanted to call out 2 insulin products on this list because I know insulin is always a big topic. Basaglar and Novolog. Basaglar is number 2 and Novolog is 5 on this list. Both are available at $10 per month for UMP members. While United Healthcare does not have these exact brand insulins available for $10 per month, they do have very similar insulins available, which are also at $10 per month. For example, one of United's preferred long-acting insulins is Lantus, which actually has the same active ingredient, insulin glargine, as UMP's preferred option, which is Basaglar. So clinically speaking, there's really no problem switching from Basaglar to Lantus or from Lantus to Basaglar. Many of the other medications listed here, including Jardiance, Ozempic, Farxiga, and also Victoza, are also used for diabetes, but they're non-insulin products. The general trend really for these brand drugs is that UMP members would pay more per month. The exception to this is Flovent, which is near the bottom there. Even though it is a brand drug, it's on the value tier for UMP with a maximum of $10 per 30-day supply. And next slide. And then finally, specialty drugs. So to remind everybody, specialty drugs account for about 1.4% of total utilization and about 58% of planned spend. As you'd expect, this list has several really high-cost medications used to treat conditions like rheumatoid arthritis, Crohn's disease, ulcerative colitis, plaque psoriasis, and a variety of other dermatological conditions. Humira, as people may recognize, which is at the top of this list, is an example of a drug used to treat a variety of those conditions. And then Enbrel, Dupixent, Xeljanz, Otezla, and Stelara would also fall into this category. Repatha, though, which is the second most used drug, is an injectable medication used to treat very high cholesterol levels. And it's notable that United Health and Kaiser Northwest don't consider this a specialty drug. They just consider it a preferred brand drug. And therefore, it is at a lower cost share than UMP for United and also Kaiser Northwest if the exception is approved for them. The fourth drug down, abiraterone, is also a little bit unique in this list. It's used mainly for prostate cancer and is an example of a generic specialty drug. And it's also an example of a generic medication that would be less expensive through United Health, for example, because for UMP, that's going to max out our generic cost share at $25, but only be $5 per month with United. Revlimid and Imbruvica are also used for a variety of cancer-related illnesses. And you'll note here, with the couple of exceptions like Repatha and abiraterone, specialty drugs are currently $25 more per month through United versus UMP. So for example, if somebody was taking one specialty medication, a member would spend about $300 more per year on that one specialty drug through United versus UMP. But as was discussed in many of the previous meetings, there's also a very significant premium savings through United Healthcare that would more than offset that. And also I should call out that Kaiser Washington, for example, covers most of these drugs at actually a lower cost share than UMP, which is also certainly a viable option for some of these members. Next slide.
Luke, I just have one question for you to share some more insights on. Can you share anything about the number of members who take multiple specialty drugs? because you did, I think, a good example of a person taking one specialty drug, it relates to about $300 more per year compared to, say, the premium. But anything about the volume of individuals or retirees who take multiple specialty drugs?
Yeah, that's a great question. So when I looked at that information closer to the end of June, there were about 50 members, from what I could tell, Medicare members who are taking more than one specialty medication simultaneously. And there was one member taking 4 specialty medications simultaneously. So that was the maximum. So if you factor in just that member, they'd be paying approximately $1,200 more per year on their specialty medication through United, which would still actually be quite a savings when you factor in the premium difference. And then this is the last slide. So the 30 drugs that I talked about today account for about 40% of total Medicare prescription drug utilization. However, I realize, and we realize, that leaves a lot of drugs that I didn't talk about today. So this is up-to-date information where members can go to either the website or call the plan to get more accurate, or not more accurate, but more up-to-date information on the other drugs that I didn't address today. And with that, I am happy to take any questions.
Tom, I see your hand up. Go ahead.
Yes. If you remember, we had quite a vigorous debate about whether to adopt the value formulary or not. And if I'm understanding the presentation correctly, first of all, when we had that vigorous debate, I was kind of under the impression one of the main arguments in favor of adopting the value formulary was that it would help the overall plan. It would help reduce the overall cost of the UMP plan. And after listening to the presentation, what I'm understanding you saying is that it did not help in reducing the plan costs, but did slow down the rate of plan increase. Is that a fair statement to make?
That is what I said was that it did slow down the rate of growth or trend increase compared to what we had anticipated back in 2019. And I also mentioned that due to a lot of different factors that change year to year, we can't necessarily attribute that slowing of the rate all to the value formulary, but we do believe it was a contributing factor in addition to other prescription drug management that we do on a daily basis as well.
Okay, second question. Oh, I'm sorry. I've got 4 questions, if it's okay to proceed, or do you want to come back to me?
No, I just wanted to give you some more insights on question 1, but if you want me, Tom, to wait until all of them, I can do that too.
No, go ahead, Dave.
I was just gonna say, because many people we had a multi-year board conversation about the value formulary, and there were a variety of different reasons that were discussed throughout that multi-year debate. One of them was cost containment aspects. The other were the equity issues that Luke re-highlighted here. There were a variety of members who were able to access a lower cost share because they went through an exception process that was not easily understood, or even not many members were not even aware that it existed. And the way the value formulary was implemented, it eliminated needing to understand and ask for that process, and instead it automatically applied. changes to what that value formula, the final version that was ultimately adopted, and where there were stronger possibilities for cost containment on some versions of the value formulary as more aspects were grandfathered in or delayed, which all had very valid reasons that were supported by the board for doing those aspects. It also had the effect of dampening the potential cost containment aspects to that amount, to the overall premium or plan cost trajectories or trends. And the other thing that's challenging with all of our benefit design conversations is one blockbuster drug can change everything and overshadow a lot of work. And so I think that was the phrase that's even on the slides, is that the value formulary's impacts were overshadowed by other things going on within UMP. So there's wanted to share some of those perspectives about it as well, to that first question.
Okay, so let's say that I'm currently taking 4 different medications and I am considering switching plans, and it really doesn't matter which direction I'm going, whether I'm going from UMP to Kaiser or Kaiser to United Healthcare, whatever way I'm going. Would it be beneficial during open enrollment to talk to the plan I'm considering switching to see how they cover that drug versus what I'm currently getting in coverage for that drug?
Yeah, I would say that it would be beneficial for you to either call the numbers listed on the number listed on this slide, or if you would rather visit the published formulary, just to, so you could compare, this is what I'm currently taking, this is how much I'm currently paying per month, and you could compare that to what they tell you at the plan you're considering switching to.
Okay, and then as you pointed out, formularies change, and one of the things that happens is the FDA is continually approving new drugs. And let's say that I read about or find out about a new drug that I think might be really beneficial for my health. And it doesn't matter, again, whether we're talking about UMP or one of these other plans, how do they go about deciding if they are going to cover that plan or that particular drug? Because they don't have to necessarily accept it just because the FDA has approved it. Is that correct?
That is correct. There is a robust review process. There's a review often done by pharmacists on those new drugs that come to market. They gather all of the data for that drug, if it's been compared to other similar drugs that are already on the market. And then it goes to something called a Pharmacy and Therapeutics Committee, a P&T committee, which is often made up of, which is made up of pharmacists and also medical doctors of various specialties. The P&T committee reviews that evidence and determines, are we going to cover this drug? Or maybe the evidence is very weak and they say, we're not going to cover this drug and wait until more evidence comes out. So there is a very robust process for determining whether new drugs are going to be covered by the plan,
and just
how they're covered as well.
And just to follow that up, so that what that means is, I read in the paper that this particular drug that I'm really interested in has been approved by the FDA. It could be literally months or longer before I find out whether my healthcare provider is going to cover that.
That's correct. Usually it's a 180-day period before it goes through that whole process. However, let's say you really needed this drug, at least for UMP, there is still a pathway for you to get that drug covered. It would just have to go through an exception process.
Okay, and one more question for Dr. Transu. You talked about in your, I think it was in the very first slide about you must be affiliated with United Healthcare. I need to know a little bit more about what affiliated means as opposed to a preferred provider or it doesn't mean the same thing when for UMP, you have to be a preferred provider. Is that what affiliated means, or can you explain that more?
Yeah, and we can take some of that as a follow-up. That is just specific to non-traditional Medicare providers in the United system. So that's sort of the term that they use for those specifically naturopaths and massage therapists. It's not a, as opposed to a traditional medical provider. I'm an internist. If I want to see anybody, United will pay me whether I'm in contract or not. It's a little bit different for the naturopaths and the massage therapists. They would have to have a kind of pre-existing relationship. And affiliated is the word that they use for those providers specifically, and we can look up and kind of get back to you. I don't know exactly how, whether that's just the categories they use to differentiate that it's a slightly different kind of provider, or how that affiliation piece for those providers is defined. So we can take that as a takeaway. But just to be clear, that's specific to that complementary and alternative medicine group.
Yeah, and
does that help?
Yes, but to follow that up also, I would ask that if I go to someone and let's say a naturopathic doctor, which by the way, my doctor is retiring, so I'm going to have to do this. And I select her to be my new doctor. I would have to, the first thing I would have to ask her would be, are you affiliated with United Healthcare? And if she says no, then they would probably not cover her. Am I understanding that correctly?
Emily, let me try to share something, because I struggled with this exact concept myself. Tom, the way I think of it, I'll just use like an SAT analogy. In the PEB world, we have retirees. That's the broad word for all members who are retired in our program. Some of them, a subset of them, are classified as non-Medicare retirees. Some subset is Medicare retirees. Sometimes you slice it as some of those retirees came from K-12, some of them came from higher education. There are all these various ways to slice up the concept of retirees. In United's world, they have providers, and then for classification purposes, mostly internally, they call some of them affiliated. They call some of them, there's like 4 different terms that they use just to kind of classify different providers. But from the provider standpoint, they either accept the plan or they don't. And whether the exact pronoun bucket header that United uses to track different types of providers, because like the healthcare authority will ask them, how many primary care providers do you have? So they have a bucket that kind of hits that concept. Or we say, how many specialists do you have? And they say, oh, that's our affiliated providers, and that's our X other types of providers. They're just ways that United classifies kind of internally those different types of providers. And the provider doesn't necessarily even know what pronoun is used for them internally by United. So we'll definitely should come back with a little bit more about this, but the terms that are being used right now aren't even necessarily terms that are used externally with the provider community. And so they might not even resonate if you were to go and ask a specific provider, are you an affiliated provider? That might not have even been a term they've ever heard, even if they fully participate and always have with United Healthcare.
Okay, and one other question. So Uniform Medical will decide whether you're going to be a preferred provider or not. Let's say that you're someone who has just come out of medical school, or you've just come out of your training as an acupuncturist or as a massage therapist. How do you become a preferred provider? What process does Regents use to decide whether they're going to allow you to become a preferred provider or not. And is it an easy process or is it quite difficult? Do they make a determination based on the population of a county as to how many they will allow in any particular area to be preferred providers? Because it seems to me, based on my limited experience, that becoming a preferred provider is not necessarily very easy to do.
Want me to take that one? As someone who's probably been through this more times than most people know about, I think there is, so every carrier has a network credentialing process. Although, as we said before, United specifically doesn't require that people go through that apart from those small categories of alternative medicine providers. Basically, if I sign up with Medicare, I get an NPI nationally from Medicare, United will pay me nothing else to talk about. I can choose to enter into a contract with them and be officially in their network. But in general, carriers go through a credentialing process. So when you start practice, you either on your own or more likely you're starting with a group practice and you've got the people who do this, you submit an application and it goes through what your credentials are, what your training is, and then they'll have a committee that will look at that. It's not looking at how many people they have in network in an exclusionary way, like, oh, we've got too many people in this network area, we don't want any more. They may do more of an outreach if I'm coming out and I'm the only internist in Ferry County in this area, they're going to be coming and knocking on my door saying, come into our network, because they've got a need there. And so they'll do special outreach when there's a need. Otherwise, it's more of if I choose to want to enter the network for any given carrier, I'll submit my application. Most of those will go right through. If I've got a disciplinary history, I was kicked out of that residency and I had to go to another residency, or I was named in a lawsuit, then they'll have a committee generally comprised of a group of providers that will evaluate those one by one. Was this action that was taken against me in whatever way part of a pattern that then raises questions about whether I'm appropriate to take care of their patients, or was it something that was either an issue that was addressed and resolved, or something that is that was sort of a one-off, I got sued, but it was for something that wasn't my fault, et cetera, kind of scenario. So that process of getting into a network is typically initiated by the provider. Either there are red flags about them in one way or another, and those will be adjudicated based on concerns about really whether they should be providing care to the group or not. And then there can be more specific outreach to try to really pull providers in if there's a shortage.
Thank you.
Is that helpful?
Thanks, Dr. Transu. Let's move to John and then Elliot. And I'm mindful of the time because I want to get us to public comment as well. So John, you're next.
Yeah, I had a question whether, I know all of the quotes you showed us for the medications were for 30-day supplies. Is there any benefit for going longer term, like 90 days? A financial benefit?
And we could follow up with the other plans, but for UMP, there's not a financial benefit from getting a 90-day supply. It's just the 30-day supply multiplied by 3. However, there is a benefit, some would argue, from a non-financial perspective, and in terms of it makes less trips to the pharmacy, convenience, adherence as well.
Do we ever approve 90-day supplies?
Yes. In fact, likely all of those generic medications that I shared today, I would say the majority of those fills for people are going to be a 90-day supply.
Great, thank you.
Elliot.
Yes, this is directed to Luke. You were referring a little while ago to a pharmacy and therapeutic committee when a new drug is announced. Does that committee answer to the pharmaceutical, not the pharmaceutical company, I'm sorry, to the plan, or are they an independent organization or association that can review these drugs?
Yeah, that's a good question. And so it depends what drug we're talking about. So for a lot of the drug classes, they go to MODA Health's Pharmacy and Therapeutic Committee, which is a committee run by MODA who administers our pharmacy benefit. And this is specific to UMP. For a lot of other drug classes, they go through a slightly different process in that they go to the Washington State and Therapeutic Committee, and that's more of an open public meeting situation where people are allowed to give public comments. And but either way, very robust information is reviewed by either one of those committees and a decision is made.
Mr. Dearden,
that would be true more generally.
Oh, I'm sorry. Can I just say a plane went by and I couldn't hear your answer, Mr. Dearden, about the name of the second committee that you mentioned.
Yeah, it's Washington, the Washington State P&T Committee, and Healthcare Authority has oversight of that committee. And
thank you.
At least in terms of selecting the members and running the meetings.
To give a slightly more general answer, every plan or the plan may have a pharmacy benefit manager who does this, but any given kind of pharmacy shop will have a committee that plays this role. And they're convened by the plan, but there are rules about who has to be part of it. You know, they're essentially always kind of community providers, pharmacists, providers. I always hesitate to say physicians because they're nurse practitioners and Max as well, et cetera. So it's going to be typically a group of active community providers who kind of convene to play this role. And it's looking at the new drugs, looking at the question of, is there a therapeutic benefit that these offer that isn't offered by existing drugs? Are there safety concerns? Where should this essentially fit into the big grid of drug coverage? So if a new drug comes on the market that is filling a niche that nothing else is filling and works well and is safe, it's going to typically have a pretty quick and easy route kind of onto the formulary. If there's something that is much more expensive but doesn't show any therapeutic benefit over others, it might fall into that step therapy category. If there's something where there are real safety concerns, then there can be some special things put into place where, for example, it's only allowable if there's an overriding reason that it's needed, and then safety tracking is done.
And for the board's understanding too, there are several other kind of national level committees that we participate in. The Drug Utilization Review, I think Oregon OHSU Center for Evidence-Based Medicine oversees that group. I think NASHB, there's several that where there are kind of strike teams or committees that go on depending on what's happening. So thank you for those questions, board members. Luke and Emily, you've been a wealth of information. Are there any final questions for these two before we turn to public comment? Dave, I don't see any other hands up. All right, there's their contact information. And thank you both again for your work and dedication to our efforts. What I'd like to do now is just encourage everybody to kind of stand up and take a little bit of a 3-minute kind of stretch break while we call for the public comment period. And I'd like, if you're interested in commenting, if you could signal with your virtual Zoom hand so we can get a queue going and get organized for public comment. So if you will signal, where's Fred? Fred's always at the top of the line. Fred, you know we say that lovingly, but please, again, signal with a raised hand if you are interested in making public comments to the board. And we will begin that process here in a couple, 2-3 minutes. Dave, so far I'm seeing Albert Berger. I bet you're making a list.
Yes, we are making a list, Sue, just as we're seeing hands raised, just to make sure.
So bear with us, board members. Hope you're stretching, and members of the public stretch. Do a little wellness breathing while we get organized.
So far, we have the 2 names that you identified as signed up. So if you want to proceed and people can continue raising their hands, it's good to know whether we have a few people or dozens of people, just to be able to organize, but I don't see a need to wait any longer to proceed if you're ready.
Okay. This is our time that we call for public comment. And as I asked, we've asked people to raise their hands and signal to us that they want to be in the queue. Staff will help me kind of organize the queue. And I'd like Connie, you and Dave to help me because you've got the list right there in the full big screen. I remind members of the public to please identify yourself, and if you'll share your name with us, who you're affiliated with, and then we ask you to, keep your comments to 2 to 3 minutes. But I think, Dave, right now it looks like we have about 5 in the queue. Is that correct?
Yes.
Great. So let's go ahead and begin.
Sure. Our first is Albert, and then next after Albert will be Linnea.
Okay, can you hear me?
Yes, Albert, we can.
All right, thank you very much. I really appreciate this opportunity to talk with your board. I am a retiree for more than 10 years from the University of Washington faculty. And throughout that time, I have, and my wife, we have used Uniform Medical Classic, the Classic plan. We've been extremely satisfied with that plan. A couple of reasons include the fact we do a lot of travel out of the state of Washington, including foreign travel. A few years ago, unfortunately, my wife was very ill and wound up in a hospital in Dubai, a hospital there, and she presented her uniform medical cards, and that we never saw a bill for that 5-day hospitalization. It was all taken care of. The other thing, as I said, we do a lot of traveling. We also live on an island, on Lopez Island in the San Juans. And, the plan has worked for us living on this remote island. So again, I wanted to make my comments short about how pleased I am and my wife are with Uniform Medical, the Classic plan. So thank you very much for me to be able to speak to the board.
Thank you, Albert, for those comments. And I'm hoping your wife recovered from her injury and that life is good on Lopez.
Life is indeed good on Lopez. Thank you.
Good. All right, Linnea, I think you are next in the queue. If you'll identify yourself and begin your public comment.
My name is Linnea Mulder, and I retired from UW-MC Montlake as an RN. I worked there for about 40 years, and I've had UMP Classic since 1975. And this is a little bit of a repeat from my comment from the previous meeting. I still feel there needs to be a detailed explanation process for the pharmacy pre-authorization appeal process. I think that would help transparency purposes. Each insurer has their own process, and it can be a very straightforward process, or it can be a multi-level, almost delaying care kind of process, where you start out with a denial, and then you do an appeal letter, and the appeal letter can need up to three articles, 3 journal articles showing efficacy of the medication in that particular diagnosis. And then if that's denied, then it usually goes to a peer-to-peer, which sounds good, but often the specialist is not matched with a peer. I worked with rheumatology and pulmonary, and they would be matched with a retired OBGYN. So it all can really delay care and have poor outcomes for the patient. So I think if we could see what the process was for both Uniform and for United, as far as what their PA process is, that would help people make a choice. And then I had another question. UHC's PBM is Optum, and MODA's PBM is Navitus. And I would be interested in knowing what the role is of these PBMs in each. If it's I just don't know, or all. Do the insurers deal with their PBMs? Do the PBMs all have the same role no matter what the insurer is? Because there's a lot of money that goes to the PBMs. And one member commented the last meeting that and I just want to confirm if this is accurate. They said that once you're on a medical advantage plan, if you switch to another medical advantage plan, that you needed to be reassessed and required underwriting. And that wasn't something I was aware of because I hadn't looked at medical advantage plans before. So that would be a good clarification also. And thank you for this opportunity.
Normally I don't try to answer questions in public comment, but I do want to address that one because there was a piece earlier today in Ellen's presentation. What you described and what was described last meeting is true in the individual market. It is not true within the PEB portfolio.
Okay. Okay.
It's totally understandable people have that question.
Sure.
It applies in the individual market, but it does not. That restriction does not apply within the PEB program if you stay in our pool around program.
Okay. Thank you very much.
And it is confusing, Linnea, because there are definitely retirees who choose to buy on the commercial open market and not go through.
Sure.
So thank you for those questions. We will respond back at our next meeting and in follow-up.
Okay, thank you very much.
Next, we have at least 3 people still. So next is Carl and then Mary. So Carl?
Okay, I'm coming slowly but surely. Carl Warren, WA, retired, and I happen to be a border town in Southeast Washington in Asotin County. And again, I can continue to be concerned about the availability of what I can have for insurance. And I have to tell you, I'm very pleased with the Classic UMP Classic, and it has been very good to me through all the surgeries and recent illnesses. I would hate to see it go away, but I was so pleased that you made the resolution to continue to look into it. And I am very appreciative of the information that I received today. So thank you. And please keep in mind the rural areas of this state. We still exist. Have a good day. Thank you.
Thank you for those comments, Carl. And we absolutely remain committed statewide and understand the sensitivities about rural urban. Mary, thank you.
Hello, my name's.
I just also, as Mary, as you're coming, I just thought also, people don't necessarily know this about my own background. I grew up in a rural community, not in Washington State, but I draw on that experience and am reminded often about how Many people haven't grown up or lived in rural communities, and that's something that I bring as an important perspective. And I'm often and regularly thinking about rural communities. It's just part of how I grew up and my upbringing, and it's something that a perspective that I'm fortunate to be able to bring to the agency's leadership team. And so just wanted to add that. Mary?
Hello, my name's Mary Lindsay, and I'm the WEA retired president. And first of all, I want to thank you for having the live transcript available. That was really hard for many members last month, and a couple went off the call in frustration because they were not able to follow the meeting. So thank you for taking care of that so quickly. I also want to thank you for the detailed presentations today. I could tell that you were really trying to answer questions that you've received either at the previous meeting or by email, and that's really that's very evident that you have done that. I also want to thank you for announcing that you really have a desire to actively listen to PEB members and senior organizations. That's really helpful. And I think that we've all learned something about people that are on the UMP Classic Medicare, that they're very loyal to that program. And they were very, very stressed out by the news that it was going to be terminated. And now they are having a little bit of stress reduction, because if you're really ill, you want to worry about getting better and not worry about what kind of program you or what insurance program you have, and that wonder if you're even going to have it. So I just want to mostly thank you, and we still have a lot of work to do, but thank you for your attention today.
We appreciate your comments, Mary, and staff, in fact, have really worked hard to just back up and try to make sure everything is being covered. And there'll be more to come, as we said, but please give us a lot of grace, because there's a lot happening with COVID and, you know, our other health policy realities too. I think, was it Elliot next or Tony? Dave?
Elliot. Tony, and then, or I think it was Tony, and then Elliot, I'm assuming, wants to speak in an individual capacity, but maybe let's go with Tony and then Elliot.
Hello, thank you for the opportunity. And I too want to thank all of you for the time you've obviously spent during the past month and previously, but to address the concerns. I've been retired since 2011 and used the UMP plan before retirement, and have continued to as I went into retirement, and I'm very, very happy with it and concerned about it going away. That said, I've been trying ever since the rates went up so much this past year. I've been trying to understand the reasons behind it. And I still, even with all the discussion last month and this month, and I listened to most of the meeting today, I'm not clear. And so let me tell you where I think I'm confused. Regarding the subsidies, has this plan ever received a federal subsidy? If yes, for how long, and has that changed? And if no, why not, if the other plans have? And the same question for state subsidies. But then following that, if subsidies have not changed, is the sole reason for the larger increases based on the financial experience of UMP? And if so, why is their experience so much different than the other plans? Is that clear? That's quite a few statements.
It is, Tony. I can I could try to give a quick, seeing that there's one more person for public comment, would love to try to give some insights to some of those questions. And we can do some more follow-up direct outreach with you as well. But the short answers is the substantial federal subsidies that the other plans receive are not and have never been received by the Uniform Medical Plan. And that's because federal law dictates what types of plans can get those federal subsidies. So Congress has passed the law, and that's codified, that sets up who receives certain types of subsidies. And so the other plans are eligible for those subsidies, and UMP is not. And so UMP has not received those subsidies in the Medicare setting. For state subsidies, the legislature sets a cap on what the subsidy is in the Medicare risk pool. That is applied to all of the plans within the Medicare risk pool, and is currently set in a way that it's a fixed dollar amount or 50% of the premium, whichever is less. The current cap is $183 or 50% of the premium, whichever is less. That cap has changed at different history. But that is a subsidy that is available from the state for any Medicare retiree, anyone enrolling in a Medicare retiree plan, regardless of what that plan is. So the state subsidy applies to all plans. The federal subsidies only flow to the non-UMP plans because of that federal law and structure of the plan. And then that was several of the questions. I'm not sure that I remember the last one.
The last one is just given that there hasn't been a change in federal and subsidies for UMP. Is the sole reasons for the large increase based on their experience with their patients, with the patients that are not with the subscribers, I guess it would be. Yeah.
It's kind of twofold. It's UMP is driven, the rates are driven on the claims experience and the projected needs to cover the cost. So if utilization goes up, which we're not saying utilization is a bad thing, we want people to get services, but as those services overall increase, there's cost to the plan for that has to be accounted for in the rates. But yes, it's based on that experience. But the other piece is those federal subsidies that the other plans access are called risk adjusted. And so as the utilization and experience and more services might be, or the population gets sicker, that is, or less healthy, that's accessing those other plans, those plans get even larger subsidies from the federal government. So there's kind of twofold. But for UMP, it's driven based on the utilization and experience, recent utilization and experience of the plan, and a projected forward trend for what the overall plan will cost. Hopefully that's at least preliminarily helpful.
And can I have information to follow up, not to take more time now, but to follow up with you or somebody who's appropriate?
Yeah, absolutely, Tony. And I'll just say from an even higher level, the United States realizes when it compares itself across the international developed nations that we aren't getting value. We aren't getting a lot of value for our money. And that's not a slam about UMP. So the federal government started incenting the plans to deliver on value. They wanted them to drive down cost and they wanted them to increase quality because quite frankly, we really are pathetic in the universal sphere of what we're getting for what we're spending. So this policy adjustment about driving towards value changed some time ago. And it's why 2 years ago, we shifted to the MAPD plan with United Health because the federal government subsidizes their profits and they subsidize that model because they are trying to drive more towards value proposition. So we'll get you some basic articles, but this is not something that's done this year. This has been in motion since really the last decade, and Washington is following suit with even our own offerings to make sure that we are really standing up plans that get you all the best value so that you're not overexpending out of your budgets. So
yeah, and my concern is that the Medicare Advantage plans basically undercut the regular Medicare. So anyway, that's a longer discussion.
Right. It's
not
just
for now.
Right. There's just a lot of information that this is just happening now. This has been happening now for years.
I'm aware of that. It's just that the premiums have only gone up significantly in the last 2 years or so.
Right. All right. Our next public commenter is our very own Elliot.
You will give me somebody to contact though afterwards?
Yes, Tony,
we'll be reached.
I would recommend Ellen Wolfhagen. Her email is in the materials a couple of places, but if you reach out to Ellen, that'd be a great starting point.
Okay, thank you very much.
I'm going to praise Chair Birch for a minute. In our last meeting, she noted that people that support our UMP coverage should perhaps help HCA and go to Washington or contact Washington because these subsidies do not apply to plans like the UMP plan. And I won't go through that totally, but they apply. This is ever since the baby Bush is what I call him, his administration, that these subsidies were applied to private Medicare Advantage plans. So that's number one. And I, for one, would be willing to march to Washington with Sue Birch. There you go, Sue. That ought to make your day. The other thing I wanted to bring up, Linnea's question, when she talked about who's the pharmacy benefit manager for UHC. Optum is owned by United Health Group, which is the parent company of UHC. And I have some concerns about that. And I was wondering if HCA could look into that. Is there obviously it's not illegal, but I do have some concerns about that. So that really was my only comment.
So Elliot, thank you for those comments. We'll follow up. As you know, we've brought to the board several times this notion of mergers, acquisitions, consolidation. We're seeing with Centene, a publicly traded company, their acquisition of Magellan. There are many that have been buying these wholly owned subsidiaries, and we'll be back at you at our board annual retreat about, again, where we have authority or what we do to kind of monitor, but you have every right to be calling that question. And there is quite a bit of information about consolidations, mergers, and acquisitions that isn't moving us in the right direction. Not we, Healthcare Authority of Washington, but writ large in the US healthcare paradigm. We'll be back at you. We can't answer the rest of your questions today, but thank you for those public comments. Dave, Connie, is there anybody else with a hand up? Because I am not seeing any. And if not, okay, we are calling again for anybody that is interested in making further public comments before we close public comment. Okay, not seeing any. Thank you for all of those comments. Your input is always welcome, and we will follow up like with every letter and whatnot. We're trying to absolutely tie this into our presentations. So we have written, we have audible, we have visuals, and we're really trying to help people come along in this conversation. It is, as many of our presidents have said, very complicated. So we're working on it, but please keep your questions coming. And we so appreciate all the respectful tones and your recognition that the staff are working hard. I too want to thank the staff on behalf of the whole board and the agency, because they really are experts and are doing just a tremendous job in trying to answer the questions. All right. We are closing public comment at this time, and I'd like to just make a few announcements. Our next meeting will be July 20th, 2022, starting at 9 a.m. It will be virtual, as we have been announcing, and we will maintain that closed caption feature. Dave, can you tell us about any agenda items or any final comments before I adjourn our meeting?
Sure. So just to put a fine point on it, July 20th is next Wednesday. It is unusual for us to have a Wednesday board meeting. All season it's, I believe, been Thursdays. But and it is also anticipated to be the last meeting of the agenda of the season. We typically publish and schedule meetings, and there's one potentially on the schedule for the 27th of July. Those are placeholders that we put on the schedule in case there is an emergency or some sort of circumstance that warrants going further into the month of July, or sometimes some years even eke into the first few days of August. But we try as hard as we can to be done in the 20s of July, because it really puts pressure on the team as we build for open enrollment the later that the board finishes its work related to setting the premiums for the upcoming year. So we are anticipating that next Wednesday will be the last board meeting. Two things that are planned for that meeting are Tanya bringing back the rate resolutions or premium resolutions for action on the non-Medicare side. And of course, it wouldn't be a meeting if we didn't have Ellen. Ellen will be here with some additional insights on some of the questions that have been gathered over the last couple of weeks. And as I said, you can anticipate Ellen being a standing member of our meeting agendas for quite a while.
Great. Thank you so much, Dave. All right. At this point, I don't see any further business that needs to come before our board. Again, on behalf of the board, I want to thank the staff. You really have been just putting in extra effort and trying to just clarify the myriad of questions. Please, members of the public, join us again next week. And for future meetings, spread the word that all of this is available. And at this time, our meeting is adjourned. Thank you all.